السلام عليكم. أهلا وسهلا فيكم بنهارنا ورشة العمل للتوثيق السريري بالمملكة. اسمي إلي داوود، أنا من أكاديمية نوبيليتي، ونتشرف بحضوركم اليوم. بنحب نبدأ نهارنا بمقدمة عن أكاديميتنا، عن نشاطاتنا ودوراتنا كنوبيليتي، وبعدين بنقدم لكم شركائنا، وإن شاء الله بنبدأ النهار سوا. الهدف من اليوم هو توعية وتدريب على أهمية التوثيق السريري، أهميته بالقطاع الصحي، أهميته بالأداء المالي للمستشفيات، خطط التحول بالمملكة، وإن شاء الله كمان بتشوفوا معنا من الناشونال كيس ميكس سنتر، وكمان بالآخر دور التكنولوجيا بدورة الإيرادات وبالتوثيق وبالترميز. اليوم نهارنا تفاعلي، أكيد نحن نكون عم نحكي ونعمل برزنتيشن، ولكن اللي عنده أي سؤال بليز وقفونا. يعني حابين الجلسة تكون تفاعلية. شو في أسئلة نحن إن شاء الله بنجاوبها. بنبدأ هلأ وبناخد بركة استراحة على الساعة 12. استراحة بتكون للصلاة والغداء، وبنرجع بنبدأ تقريبا على 1:15 1:30 وبنكمل نهارنا سوا، وأكيد في شورت بريكس خلال العرض. ف مين نحن؟ نحن أكاديمية تختص بمجال التدريب في الرعاية الصحية. حقيقة بدينا من كذا سنة بدبي، ومن أكثر من سنة توسعنا على المملكة وعملنا برامج متخصصة للمملكة بناء على متطلبات المملكة الخاصة. بدينا بالأونلاين كورسز، وهيدي صراحة كانت مهمة وضرورية، خاصة بزمن الكورونا لما الكل كان جالس ببيته. التريننج كان كله أونلاين، فبتلاحظوا انه كل دوراتنا موجوده اونلاين، وهي مش عباره عن انه كتيب اونلاين بتبرم الصفحه فيه، لا، كورساتنا تفاعليه. ما فينا نعمل مثلا سكيب، ما فينا نعمل نكست. في اشخاص افتراضيين بيطلعوا قدامنا بيحكوا معنا، في اسئله، في اجوبه. ما فينا مثل ما بيقولوا نقفي ونستعجل لنخلص. الكورس بردنا للاول اذا حاول المتدرب يتخطى مراحل. أكيد عندنا كمان تدريب للمؤسسات والمستشفيات. هون يعني إذا مش الفرد هو بده يطور نفسه، أوقات المستشفى بتستثمر بتطوير الستاف اللي عندها على مجالات عدة. عندنا كمان حلول بنسميها كاستمايزد، هي مور مثل الاستشارات والكونسلتنسي وتأسيس الإدارات والسياسات والإجراءات وكل هالأمور هاي. يعني هيدي تتعدى التدريب وتدخل إلى أكثر الإدارة ومساعدة المستشفيات بتأسيس إدارات جديدة وفانكشنز جديدة. وبالآخر عندنا برنامج تطوير الشباب، اليوث ديفلوبمنت. هيدا بالمملكة كان كبير كتير، لأنه مثل ما بنعرف على ال5 سنين الجايين مثلا في مهنة المرمز الطبي رح يتم توطينها. إن شاء الله كمان في مهنة جديدة للتوثيق السريري، فهي كلها للشباب والشابات السعوديين. عندنا برامج نحن بنشتغل فيها مع الحكومات لخلق وظائف العمل وتدريب الشباب، الجيل الجديد ليستلم وظائف المستقبل. لمحة سريعة عن البرامج اللي عنا إياها. واليوم أكيد عارفين أنه حديثنا رح يكون عن التوثيق السريري، ولكن لمحة سريعة. نحن دايما بنحب نعطي تركيز وأهمية على التوثيق السريري، لأنه بنعتبره من أهم أولى خطوات إدارة دورة الإيرادات. يعني لما نبدأ بتوثيق سريري صحيح من الطبيب، عم نضمن رعاية صحية عالية، عم نضمن انه الترميز الطبي اللي من بعده رح يكون دقيق، عم نضمن انه الفوترة والمطالبات لشركة التأمين رح تكون مقبولة، يعني منخفف نسبة المرفوضات. شو معناتها؟ معناتها تحسن الأداء المالي للمستشفيات، معناتها استدامة للمستقبل للمستشفيات، وخاصة بالقطاع العام حاليا بالتجمعات والمستشفيات الحكومية. مع التحول اللي صاير بالقطاع الصحي بالمملكة، مطلوب استدامة مالية للمستشفيات. فمن هون أهمية التوثيق السريري، ومن هون كان خيارنا اليوم مع شركائنا إنه تكون ورشة العمل عن التوثيق السريري. وأكيد البرامج اللي عنا مكتوبة خصيصا للمملكة. الأهمية نحن عنا كأكاديمية إنه مش بس نجيب شركات عالمية لنجيب اسم أجنبي بمحتوى أجنبي، هدفنا نجيب اسم أجنبي بيعطينا level of comfort عن نوعية، ولكن يكون المحتوى محلي. لأول مرة فينا نقول عنا شهادة توثيق سريري بالمملكة معتمدة عالميا من أهيما، ولكن المحتوى هو للمملكة. عندنا كمان برامج على برنامج تدريب على الترميز الطبي اللي مبني على نظام الفوترة السعودي. مش بس على الاي سي دي 10 اي ام، مبني كمان على نظام الفوترة السعودي، وكمان معتمد من شركائنا بأهيما. عندنا بعدين كورسات للبرايفسي اند سكيورتي بالقطاع بالمجال التكنولوجيا الاي تي للمستشفيات. عندنا كورسات عن التحول من النسخة السادسة للعشرة بالترميز، عن الكوستنج، وهيدا موضوع قريبا رح يصير مطلوب بالمملكة، خاصة بعد ما نطبق الدي ار جيز. المستشفيات بدها تبلش تفهم كيف بتتكون تكلفتها الداخلية لكل الإجراءات، لنقدر نقارنها بعدين بالأسعار والدي ار جيز المطبقة على المستشفى، لنعرف وين في تحسين مطلوب بالأداء المالي للمستشفى. عندنا كمان كورس معتمد من احدى شركائنا اللي هن اسمهم HFMA، هلا بخبركم عنه، بالمجال المالي بدورة الإيرادات. يعني هيدا الكورس اللي اسمه CRCR هو للعاملين بالإدارة المالية بدورة الإيرادات. وأكيد نحن بندرب المدربين للي بيحب يكون عنده فريق داخلي جوا المستشفى للتدريب. وعندنا كمان على الاوديتنج ودوره اداره الايرادات الكامله، كورسات شامله عنا. مين شركائنا؟ مثل ما قلت لكم نحن كان هدفنا ما يكون بس انه نحن اكاديميه مثل باقي الاكاديميات، نحن هدفنا يكون عندنا شركاء معتمدين المحتوى عنا، المحتوى المحلي، ليعطيكم تطمين وجوده عالميه بالتدريب. هون لا تأخذوني رح اقلب على الانجليزي شوي بس لأعرف شركائنا. I'll switch for a few minutes to English. So I would like to introduce AHIMA, who are our first partners. They'll be on stage in a few minutes after me. AHIMA is a globally known organization. I think some of you also are AHIMA members and certified. They are our partners in multiple courses like the Clinical Documentation Improvement course for Saudi and the medical coding based on the SBS system for Saudi. I'll switch back to Arabic now since we're not talking about AHIMA. now. شركائنا التانيين هن HFMA اللي هن Healthcare Financial Management Association. هي كمان منظمة أمريكية عالمية عمرها فوق 75 سنة، تختص بالشأن المالي بالقطاع الصحي. وعندنا دورة معهم اللي شفتوا اسمها CRCR GCC. هاي الدورة دورة تدريب على مجال الRCM، تخصص مالي، والمحتوى مكتوب للمملكة العربية السعودية، وفيها كمان محتوى مكتوب لدولة الإمارات. فاللي بيحصل على هيدي الشهادة من عنا عنده شهادة بمجال دورة إدارة الإيرادات معتمدة عالميا من أهيما، المحتوى لدول الخليج. يعني الحاصل على هاي الشهادة فيه يشتغل أو فيه يطبق معلوماته ومعرفته بأي دولة بالخليج. أكيد الشهادات المعتمدة من أهيما معتمدة دوليا، يعني الحاصل عليها بياخدها وبيروح بأي مكان بالعالم. كمان عندنا كورسات تم مراجعتها واعتمادها من مجلس الضمان، وكمان كان عندنا تعاون مع المجلس الصحي السعودي، خاصة لما حكيت على برامج تطوير الشباب تدريب الشباب على أخذ الوظائف المستقبلية بقطاع الترميز الطبي. وين حاليا موجودين أو وين نحن حاليا؟ سو فار دربنا أكثر من 3000 طالب، عندنا أكثر من 11 كورس، تقريبا أكثر من 20 موظف، أكثر من 5 شركات. مكاتبنا وفرقنا موجودة على الأرض بالمملكة، بالإمارات، بالهند، وعندنا شركات وعندنا كمان مستشارين بيشتغلوا معنا منجيبهم على الأرض هون على التدريب من أمريكا ومن أستراليا. يعني في مثال أوقات بيكون عندنا دورات تدريب طويلة فيها ورش عمل مدتها بيكون أسبوع 2 3، ما بنعملها بس فيرتشوال، بنجيب الاستشاريين اللي عندنا بيقعدوا على الأرض الفترة المطلوبة وبنقدم دورات التدريب كاملة. بعض الأسماء والجهات اللي كان لنا الشرف نشتغل معهم: IMC بجدة، الموسى بالأحساء، وزارة الصحة، النهدي، مستشفى الملك فيصل التخصصي، جامعة الملك سعود المدينة الطبية، التجمع الشرقي الصحي، والهيئة السعودية للتخصصات الصحية. هاي بعض خططنا للمستقبل. خليني بس لكم عن المملكة. خططنا للمملكة تتضمن من أهم الأمور مساعدة القطاع الصحي على تأسيس إدارة التوثيق السريري. هون اللي بيكون عندنا إدارة تختص بالحفاظ على جودة ونوعية التوثيق السريري. فرق بتكون اتدربت معنا لتتعلم كيف تراجع الملف الطبي من بعد الدكتور، وتتناقش مع الدكاترة على شو لازم يكون تغير أو تحسن بالتوثيق لنضمن السلسلة اللي ذكرتها من قبل، اللي هي تحسين التوثيق، تحسين الترميز، وبالنهاية تحسين المطالبات التأمين لتخفيض نسبة المرفوضات ورفع نسبة الإيرادات للمستشفى. أكيد عم نشتغل كمان بعدنا على اليوث ديفلوبمنت. بدنا نركز هالسنة كمان على الدي ار جي والكوستنج، لأنه هالسنة موضوع الدي ار جي رح يطبق تدريجيا بالمملكة. والفاينانشال مانجمنت، الإدارة المالية، مثل ما قلت لكم الكورس اللي جبناه من كم شهر مع HFMA. ما راح ادخل بباقي المناطق، I don't think هي كثير لها أهمية لاجتماعنا اليوم. بالنهاية بحب أشكركم، ما راح أخذ وقت أكثر من هيك بالمقدمة. راح نكون موجودين سوا اليوم، اللي عنده أي سؤال نحن جاهزين. And now I would like to introduce AHIMA and my colleague Matthew Spurgeon to speak on behalf of AHIMA. Thank you.
Assalamu alaikum. Good morning. My name is Matt Spurgeon. I'm with the American Health Information Management Association, or AHIMA, and we'll talk to you a little bit this morning about AHIMA as an organization, what it is we do, and a little bit about the partnership that we have with KNWBILITY. Later this morning, some of my colleagues are going to share a lot of information with you about the process and the history of clinical documentation integrity, or CDI, but we'll give you an overview right now of AHIMA together. So AHIMA is a not-for-profit organization. We're an organization that takes all of the revenues that we receive and put it back into the mission to commit to the excellence in the management of health information globally. And when you think about how health information has changed over the past 20 years, and certainly over the past 5 years, that change has been truly revolutionary. And so we think this mission, which we've had for a while, is more important and more relevant than it's ever been. And we also exist to support all individuals that work inside the health information management world. And increasingly, as an organization, we're taking a broader view of what it means to be a health information management professional. Certainly, anyone that works in the HIM field, from coders to clinical documentation integrity specialists to data analysts, we would say work in health information. But increasingly, we're making the case that everyone in healthcare has a role to play in health information and health information management. There's much to be learned, there's much to be used with that data. We believe in a world where healthcare is transformed by health information. We're not just using health information to manage coding and billing, but we're transforming the way we deliver clinical care at an individual level and at a population level. We also believe that when clinicians and consumers have access to the appropriate and accurate information they need, they can optimize care. We spent some time earlier in the week talking about the value-based healthcare agenda and how that connects to data. And there's an important conversation that we're helping to have around how we look at data, how we look at health information, and how that relates to cost information, expense information, how we can optimize that in a world where healthcare is becoming increasingly more expensive and difficult to provide for. And we also believe that health information professionals should have a seat at the table, should be a leading voice and a driver in conversations around how do we optimize outcomes, reduce costs, and provide the best care possible. We work with organizations around the world. We spend a lot of time working with intergovernmental organizations. We're a member of the G20 Health and Development Partnership. We've also done work with the World Bank and others. We've worked in countries around the world. I've given you a couple of examples here, but we work with countries really all over the globe. So from a content area standpoint, these are the areas that AHIMA typically focuses on. One of the areas that we're most well known for is data structure, content, information, governance, and coding. We spent the past probably 30 years spending a lot of time thinking and talking about how we govern information better and how we code that information better so it works in our healthcare system. That's an area that we spent a lot of time talking and being interested in. Informatics, analytics, and data use is another part that's really a growing piece, I think, of the overall healthcare emphasis, and certainly a growing piece of what we like to talk about. Once the information comes into our system in a way that's accurate, in a way that's helpful, how are we taking that information and translating that into useful insight? Useful insight at a clinical level, useful insight at a managerial level, useful insight at a population health level. Today, we're going to spend an awful lot of time talking about clinical documentation integrity, or CDI, so I won't go much into that at this point. We also look at revenue cycle management. How are we taking the information and leveraging the information to optimize our financial outcomes? We spend a good amount of time talking about clinical foundations. What we've discovered over the past several years is that there are a number of people in the healthcare system that are health information management people that don't speak healthcare, and a number of people who are clinical leaders that really don't speak health IT. And so one of the focus areas that we have is to try to teach each other the right language to be able to speak to one another and have productive conversations. That's what we talk about in clinical foundations. Privacy, security, and information protection is a big focus area for us as well, and also an increasing area which is increasing with urgency every day. And then we also talk about health law and compliance and leadership development. And leadership development is an important area for us because we know that lots of insights are being pulled out of our health information management system. Lots of leaders exist inside of health information management programs, but it's sometimes difficult for them to understand how they should be relating to the leaders in their healthcare organization. So how do we turn the promising leaders in health information management into the leaders that can interact effectively with their hospital or healthcare organization leadership? Who do we work with? We work with people through all areas of the healthcare spectrum. Healthcare workers, for certain, we spend a lot of time with. Healthcare organizations as a whole, we work with. We work with ministries of health. We work with universities to help design the right curriculums that prepare students to be able to enter into healthcare systems effectively. And we work with supporting organizations and vendors. So we try to touch all aspects of the health information system. What do? We do 5 major things, and I'll go through each of these in piece, but educate, certify, partner, advocate, and assist. From an education standpoint, we have a wide variety of programs that exist to help educate people inside the healthcare system or people who want to join the healthcare system to know what it is they need to do to optimize health information practices. So train-the-trainer programs, workshop programs, programs like what we're doing here today, custom education, and increasingly a much broader portfolio of online education. We've always been committed to online education, but over the past 2-3 years, for reasons I think we can all relate to, this has been an area that we've spent a lot more time growing. We also certify individuals. Individuals within the healthcare system that have a particular set of skills can be certified by AHIMA. We have a number of certifications, but the one that I think is most relevant for us to talk about today is Certified Documentation Improvement Practitioner, or our CDIP program. So that's a program that we'll talk a little bit more about today. We we partner with a number of organizations like KNWBILITY, and then other academic institutions, associations, and ministries of health. We also advocate through our work at places like the G20. We advocate for the important issues that we think should be driven forward for health information management on a global stage. So this is AHIMA in a nutshell: educate, certify, partner, advocate, assist. These are the areas that we focus on. It gives you a sort of a broad overview of AHIMA. Any questions before we go on? All right, well, it's with great pleasure that I'm going to welcome down Tammy Combs. Tammy is our practice director for clinical documentation integrity programs. She is a wonderful speaker with years of knowledge on this topic, and I'm very happy to turn over the microphone to her today.
Good morning. Thank you for having me this morning to talk about a topic, like Matt said, that I have worked in for many years. I think CDI has been about 14 years. And, okay, let them pull up my presentation. I'll tell you a little bit about myself. Yep, there we are. Nope. Okay. Start. Okay. So here at this first part, we're going to talk about what CDI is. Many of you may be familiar with CDI, but we're going to do a little bit of a refresher on CDI. I'm going to bring in a few case studies. We're going to have several case studies throughout the day. And so in my case studies, we're going to talk about some of the opportunity that you see within the documentation, the clinical documentation. And then as we get into this afternoon, we're going to dive into some of the impacts that we see. I'm going to talk about the impacts this morning, but we'll bring in some scenarios that helps you identify that impact financially and to that complexity score that you have. So what is CDI? Whenever we think about CDI, it is to facilitate the accurate representation of the patient and the care that was provided. All of us that work in healthcare, my background is nursing. I've been a registered nurse for over 21 years. I've worked in healthcare for a little over 30 years now, and then CDI for 14 years. And so in healthcare, I've worked with a lot of different professionals. We work really hard to take care of our patients. That's why we came into healthcare. And so we want to make sure that we accurately represent that care we're providing. And we're seeing the impact on a much larger scale as we continue to evolve with technology and the pay-for-performance that we see occur. So whenever we talk about CDI, we think about the 7 characteristics of high-quality clinical documentation. Now, AHIMA, as Matt had mentioned, we've been around for a while. And whenever we started, we really, we touched so many different areas. But whenever we first started, we really focused on coding accuracy. Well, all of our coding professionals out there really started to notice that we could code out these conditions to this higher level of specificity. That word we use a lot in CDI. We want to be as specific as possible in the documentation. And so in doing that, CDI was born, and it has continued to evolve now, where it can, and depending on the organization, you'll see those individuals who are independently focusing on the documentation itself, getting that documentation to where it needs to be. So whenever the coders come in and code out that information, it is as accurate as possible. So these are the characteristics that we really look for. And whenever you think about these characteristics, they can be applied to many settings, well, pretty much all settings and all locations, because we can really build up from these characteristics. These are complete, consistent, timely, clear, precise, legible, and reliable. So let's look at these in a little bit more detail. So complete documentation, what do we mean by that? That is documentation that's very thorough. It's addressed all the concerns that that patient has presented with, and it has been authenticated by our providers as well. So let's look at some examples. So a physician comes in, they order a swallow evaluation on a patient, but there's no documentation as to why it was ordered. You'll see the order come in, but we don't have a diagnosis to support it. This would be an opportunity. It's not complete. And if we see something like this, then it results in a query. Whenever we send the query, we want to clarify with our physician the documentation. And we bring in that higher level of specificity, or in this case, a diagnosis itself as to why we did the test. So this other example, patients admitted with COPD. Nursing notes indicates that this patient has pedal edema, and the physician orders Lasix to be administered through the IV and documents COPD with continued shortness of breath will monitor. Now, in this situation, I still wouldn't recognize this as being complete documentation, because whenever we think about a COPD patient, we can have COPD patients who are compensated and they're doing well, or we can have that exacerbation. And this patient's also at risk for complications that may be coming in. We see Lasix, I would be looking out closely for heart failures, there are any renal issues, what's causing a fluid overload, and look for that. There's a good chance we could have an exacerbation occurring. And then we have consistent. So consistent, we don't have any contradictions in the documentation. We want this consistent theme throughout the documentation. So our example, we have a patient admitted through the emergency department with syncope and an altered mental status. And so the attending physician comes in and they're documenting a TIA. And then our neural consult is given, and it indicates in that note that the patient's had a CVA, stroke. And then the attending note the next day says that the patient is stable. So what do we have? Was it a TIA? Was it a stroke? We may be able to dive into that record and do some more research and try to figure that out. But whenever we're looking at documentation integrity, we want to make sure our physicians are looking through the record whenever they're doing the consult and there's nothing conflicting. It can be easy for physicians to, they document diagnoses, especially now that we have technology, we have the electronic health record. It's easy to copy things forward, copy and paste information, and that can get copied over day after day. And we need to make sure that each note is updated and we get an accurate capture of the condition. Because as we all know, a stroke is a much higher level of acuity than a TIA. So timely. We want to make sure that the information is given as close as possible to the time of the encounter. Now we have to be reasonable with timely information. If a patient is in distress and the provider needs to take care of that patient, it may be a little while before they can then go document the information. But we want it to be as timely as possible. So let's look at an example. So when we see this a lot is whenever we think about a condition, if it was present whenever the patient was admitted to the facility, or did it occur in the facility? Whenever we have patients coming into a hospital or a clinic, we don't want to make them sick. We want them to get better. That's what we're focusing on. We want to make sure the documentation supports that. So this patient here is admitted with malnutrition, metastatic breast cancer, and day 3 progress notes indicates a stage 4 pressure ulcer on the left heel. And this is the first time documented, but wound care was ordered on admission. So those of us familiar with pressure ulcers, you know, as get to a stage 4, it's going to take a little longer than 3 days usually, unless they're in a Kennedy ulcer and actively in the dying process. So, and we've got wound care on day one. So more than likely that was present whenever that patient was admitted. So this wouldn't be timely documentation. And we want to encourage that timely documentation, what is occurring whenever the patient enters the facility and whenever a condition does occur. Clear. So we want to make sure there's no ambiguity within the health record. We think a lot about ambiguity. We want to make sure, again, that it's all very clear and specified and clear. And like I said, clear. So this patient here presented with chest pain. They've got elevated cardiac markers. They're in AFib with RVR that's noted on the EKG. All notes indicate the reason for admission is chest pain. Well, in this example here, looking at this record as a CDI professional, I'm thinking there's probably more going on than just chest pain. I'd want to have a conversation with my physician to determine maybe we have demand ischemia that's occurring. Maybe we have a type 2 myocardial infarction that's occurring. We've got some risk factors that we see in here, but only thing we have is a symptom, chest pain. But there is evidence that it could be something more. So in this situation, it wouldn't be clear. And so we might need to send that query to the provider, to the physician. Precise. So we want to make sure the documentation is as precise as possible. Now, whenever I think about precise, that's whenever I'm really thinking about that specificity that I was saying. We want to be specific. It needs to be accurate. It needs to be exact. And it needs to be as strictly defined as possible. Now, whenever I talk about precise documentation, what I mean by that is as precise that is supported by the clinical evidence. There are going to be times whenever patients come in and maybe a physician cannot give us the level of detail we hope for because they just don't know. They're working that patient. And so we have to be realistic in what we're looking for. Sometimes a patient will come in and we don't know what the underlying cause is. In that case, then we would ask them to say that the etiology is unknown. That tells us clearly that we don't know the etiology of the condition. So in our example, this patient's admitted with a CVA, or stroke, left-sided weakness, and the nursing documents patient coughing when drinking liquids. Dietary consult recommends thickened liquids and swallow evaluation. And so the swallow eval reveals aspiration when drinking the liquids. Day 3, patient spikes a fever, and the physician documents pneumonia. Okay, so we know we've got a stroke, and we know we've got documentation of pneumonia, but could we be more defined, more precise in this documentation? Because in this scenario here, there's enough evidence that we could ask the question if this is an aspiration pneumonia, because as we know, aspiration pneumonias are much more complex than a simple pneumonia that's coming in. Legible. So we want legible, whenever we think about legible documentation, we want it to be easy to decipher. And whenever we think about easy to decipher, whenever I first started in CDI, those were handwritten notes, and maybe we could not read that handwritten note that was given. You can see my example here of a actual note that was written. Pretty hard to decipher what that was. And we still have healthcare facilities that are doing handwritten notes. If we cannot read what's documented, then we may need to send a query for that clarity. But also, whenever we're talking about the electronic health record, we can still get to times where it's going to be hard to decipher what's being documented. And so the example I have here is acute respiratory failure. It's copied forward in the EHR. So I know this is something we see, a lot, especially in the United States. Patients are coming in through the emergency department, and the physician's working up several different possible conditions, those differentials. And so they may write out several different diagnoses. Well, this one here, acute respiratory failure, was copied forward in the EHR, but the patient was found to have non-labored breathing and 98% O2 sat on room air. So whenever we're looking at this scenario, it doesn't really look like a patient with acute respiratory failure. So this is a little hard to decipher whenever you get notes that are copied and pasted into the health record, they're copied forward, but they haven't been authenticated. So you can see where some of these characteristics then can overlap as well. So that's where we run into that legibility, or what we think about legibility within the world of the electronic health record. Reliable. We want our documentation to be reliable, trustworthy, safe. So we have this patient. They're admitted to the hospital with a GI bleed. They come in with a GI bleed and they have to have 2 units of packed red blood cells. And the only diagnosis that we see is a GI bleed. Now, whenever you start looking at this, you may think, well, that sounds pretty reliable. They've got a GI bleed. They had to have, 2 units of packed cells. So, what else do we need? But what we're looking for is not every GI bleed that comes into the facility is going to need blood. They're not going to all need a blood transfusion. So this patient is going to be more complex than a patient that comes in with a GI bleed, but they're stable. So what are we looking for? We're looking for a possible additional diagnosis. Probably acute blood loss anemia is a condition that we would be looking for in this type of scenario. So you have conditions, but you have to really get in and look at the details to determine, is that truly reliable based on that condition itself? Would every patient that presents with this condition have to have this same level of treatment? If not, then there may be another condition that should be brought into the documentation. So this patient was admitted with COPD, and they report being on home oxygen at home continually. The only diagnosis we have is COPD. So in this type situation, we're also looking at reliable. Now with our COPD patients, as we know, whenever they're first diagnosed, they may be very stable and doing very well. But as that disease progresses and that case becomes more complex, there may be these comorbid conditions that occur, and that's what we start looking for. In this scenario, they're on the home oxygen. Well, that's telling us something there. It has advanced. They need the oxygen all the time, where whenever they were first diagnosed, well, most of the time, whenever they're first diagnosed, they may not need that home oxygen. So what we would be looking for in this scenario is a possible chronic respiratory failure. This patient has now advanced to that chronic respiratory failure. So they can still have the compensated COPD, but they have these additional comorbid conditions that truly represent their complexity. So queries. Wanted to talk a little bit about queries, because in CDI, this is what we do. We find these gaps. We look for the 7 characteristics. When is there a gap in the documentation? But once we find that gap, what are we going to do? We're going to send a query to the physician. But we know that our physicians are very busy. They're seeing many patients and working on complex cases. So when we send this query, there are different ways that you can send it. With the electronic health record, that's really opened up the door to many possibilities of sending the query to them electronically. And then you can send the paper query as well if you're still on the paper health record. And you can also do verbal queries. So we have several avenues that you can do these queries, but there are compliance standards. And what I'm going to talk about over the next few slides are the compliance standards. What we've done as AHIMA, we've been focusing on CDI for many, many years since, CDI began. And we bring together experts and pull together publications with our practice briefs and our multiple publications. They're never just written by 1 or 2 individuals. We bring in multiple perspectives to try to come up with some standards that can really guide the industry in developing some of these processes. So with queries, here's I'm going to discuss some of these standards that we've come up with. Non-leading. So whenever you're working with physicians, they understand their patients. We don't want to go in and just tell them what to do. We want to be a resource to our physicians. So whenever we're writing a query, we're trying not to just lead them, tell them exactly what they need to do. We want them to use their medical judgment in bringing in that clarity. We want to provide relevant clinical indicators. So as a CDI, we're reviewing all of the evidence, and we want to bring that forward in the query. So we're asking many times we're asking a question. Sometimes queries can be a statement. We want that clear statement of the issue. We want to have support. Why did we even ask the question? Because by pulling that together, then we're making a clear statement to our providers as to why we're even asking this question itself. We're looking for sepsis on a case. Well, if we are, then we should probably on that query be including our white count. If they're treated with antibiotics, was there any pressors given? Are they in the intensive care unit? All of that information should be included, but only what is applicable. With the electronic health record and the different software, which later on this afternoon, I'm going to talk a little bit about software whenever we talk about and the different technology with artificial intelligence with CDI. But with that, there's a lot of data that can be pulled in. And so we have to be mindful that we don't overwhelm our physicians, so that we pulled in so much data into an electronic query that now they don't even know what we're asking. So I'll dive into that a little bit more this afternoon whenever we look into the future of CDI. But the key takeaway here is what are those relevant clinical indicators? So the query to have for an efficient query, we want to make sure there's some standards we include, the patient information, if you have an account number, and also the CDI professional, if there is a point of contact for that physician, it's nice to have that on there as well. So if they have questions, they can then know who to contact and ask those questions to. So our statement of issue, again, we talked about the relevant clinical evidence. We want the physician to make interpretation based on their medical judgment. And we don't want that query to sound presumptive, like we're telling them what to do. Multiple choice queries are the queries that we see most often, where you can ask a question and then you have multiple options that you include on that question. And in doing so, what we like to see is in addition to the list of options that we're writing out, other explanation of clinical findings or just there's an area where they can write something in that maybe the CDI, or if you're using the artificial intelligence computer, did not have built into that logic, or the CDI professional did not list out. And then there's other options that you can include on there. Unable to determine, findings of no clinical significance, no further clarification is needed. And so a lot of those get into the metrics. You can add on to the queries to monitor the success of the program. And we have a publication out just on key performance indicators and what you would be monitoring. And we go a little bit more in depth in why you might want to include some of these other options on a query. Okay, so here's an example of a compliant query. We're asking them up here at the top, based on their medical judgment, we're asking them to confirm a diagnosis. We've listed out here the diagnoses that appear supported by the clinical evidence by our CDI professional. We've given them an opportunity here to write other explanation. We've used unable to determine. And then we get down here, we have our statement of the issue. We're given a little recap, a summary of what is occurring, what we've identified in the health record. And then the signs and symptoms down here that's associated, that's your clinical evidence. Now, these queries can be formatted a little bit different as long as all of the compliant components are there. This is just an example that we use like from our query template library, which I'll discuss that here in a minute, some of the benefits from using templates that you have for queries. Okay, so let's look at some more case scenarios. This patient is proceeding to the hospital with left lower extremity swelling, shortness of breath, a bloody sputum, feels like her heart's beating fast. History is unremarkable, no medications, but we do an ultrasound. It's positive for a DVT of the left femoral vein, D-dimer's positive, and we see massive blockage in the pulmonary artery with our VQ scan. We can see our vital signs are abnormal. And down here in our ED position, they're documenting DVT of the left femoral vein and shortness of breath. And so our attending physician, when we've got a non-rebreather ICU and the patient started on heparin. So our attending physician documents DVT of this femoral vein. They're going to continue the non-rebreather, possible thrombolysis versus mechanical, and then they're consulting pulmonary and cardiovascular. Day 2, we have documentation of our DVT, shortness of breath, status post thrombolysis. So this one here, we're missing something. We've got our DVT, documented, and that's great. We definitely have a pretty high acuity. They're in ICU. We're doing quite a bit for them, but we don't see mention of this massive blockage. It looks like we have a PE that's occurring in addition to our DVT. But that's not mentioned by our physicians. And so that's something we would be looking for. And whenever you talk to your physicians, I mean, you look at the clinical picture, it's pretty clear, looks like a PE, but if it's not documented, it may not be able to be captured in that coding classification, and that can have a major impact to your complexity level. So this one here, patient presents as a direct admission to a hospital from a physician's office with shortness of breath. And so we have a medical history of CHF, COPD, hypertension, and we can see we've got some abnormal findings here in our lab work. Chest x-ray, we've got cardiomegaly, pulmonary vascular congestion, and we've got trace bilateral pleural effusions. So in our documentation, we have CHF, pleural effusions discharged tomorrow after Lasix and diuresis. So in this situation here, we have documentation of our condition. We have congestive heart failure. We have our pleural effusions, but we're missing a level of precision because we don't know what type of heart failure that we're dealing with. We don't know if it's acute or chronic. Now we can tell here, it looks like we've got some acute heart failure occurring, but we really want that in the documentation. And whenever we think about heart failure, usually this is a chronic condition. Is this brand new? Is it acute heart failure? Is it acute on chronic heart failure? Has this been occurring for some time? So that's a level of specificity, that word, that precision that we're going to be looking for with those heart failure patients. Okay, so scenario here. Patient presents as a direct admit from a physician's office with a history of dizziness, loss of balance, nausea, ringing in ears. Attending physician comes in and documents Meniere's disease, treatment, Dramamine, and Zofran. Now, whenever we look up here, we can see that a Meniere's disease is hypertrophic gastropathy. But do we see anything about GI in our scenario? We don't see anything that really supports a GI issue. So, but we do have loss of balance, nausea, ringing in the ears. So looks a little bit more like Meniere's disease than Meniere's disease. But if you're doing a transcription, dictating something like this, it's very easy for these words to be transposed. So in CDI, we have to constantly be looking for, again, that constant theme in the documentation. Is it truly reliable in what we're seeing? So in this case, we might need a query because we don't have any evidence to support that diagnosis. And it looks like it could be, something that pulled in on transcription. Okay, so this scenario here, patient presents to the hospital from a nursing home, cough, shortness of breath, green sputum, dementia, COPD. We've got a left lower lobe infiltrate. We got our lab work, shortness of breath, cloudy urine. This is noted on our nursing assessment that we see. Physician in the emergency room is talking about left lower lobe pneumonia or left upper lobe pneumonia. And then the attending, again, they're consistent, left upper lobe pneumonia, COPD exacerbation. And we even get as evidenced by wheezing on exam. Now that's one thing we love it whenever our physicians actually provide the evidence that they're using to support a diagnosis. So that's a win right there. But we're starting duonebs, so respiratory therapy treatments, solumedrol, and dementia is at baseline. So we know we've got some altered status, but we're at baseline, so we don't need to really go after that. Well, you could probably go for the type of dementia. Then we've got our attending. I talked about on day 2 and 3, the attending still have our left upper lobe pneumonia, COPD exacerbation has now resolved. So we're seeing some improvement. That's good. And then on day 4, left upper lobe pneumonia, COPD at baseline, UTI. So in this one here, this could be a timely issue because we've got a nursing assessment. Day 1 addresses this cloudy urine. And so, there's not a UA that is listed here on the scenario, but that's something, if I saw that documented in the nursing notes, I'd want to see, did they do a UA? Was that reported out to our physician because now on day 4, we've got a UTI. So did something happen? We gave that patient a UTI while they were in the hospital? Well, likely not, because it was already cloudy on admission. So we'd have to do some investigation and determine if that UTI was there and present on admission. So that's an example of what we can see with our timely documentation. All right, so that kind of goes over our refresher. And I'm going to pause for a moment and see if there's any questions. And then I'm going to talk a little bit about transformation and where we're seeing the value of CDI. Any questions? I think we're coming with a microphone.
Improvement to clinical documentation integrity.
Well, that's a great question. So whenever we started out, and the question is about why we now focus on clinical documentation integrity instead of clinical documentation improvement. So whenever we first started out in CDI, it was all about improving the documentation. And there's a fine line whenever we're talking about improving something and just focusing on the integrity of something. What we started to hear from the industry was, you're telling me to improve my documentation, but really what you're looking for is to make sure that documentation is of a high level of integrity. So the consensus from the industry after, feedback from multiple groups, our physicians, our nurses, CDI professionals, coding professionals, they're like, we're not just trying to improve, we're bigger than that. We're focusing on the integrity of the health record as a whole. And we're going to talk a little bit about those impact areas. Today, we're going to focus a lot on financial impact, because that's definitely one of our biggest that we see out there is the financial impact, but it's so much bigger with the impact that documentation now has on quality measures, on research, on that pay for performance with the financial. And so the decision was made after several discussions, focus groups, and then presenting this to the board to change improvement to integrity, just because we felt like that better represented where the industry is right now. Does that answer your question? Okay. And yeah, you probably noticed as Matt was discussing, our credential is Certified Documentation Improvement Practitioner. That exam will go through an update this year, and when it does, that title will be revised to Clinical Documentation Integrity Practitioner. And anybody that has that credential, that title will automatically be assigned to those credentialed individuals. Thank you for the question. Any other questions? Because I'll be ready for my next presentation here momentarily. See if we have a microphone so everybody can hear.
Thank you. Very informative presentation. My question it sounds like the clinical documentation specialist has to have a committed education journey. Obviously rich experience is needed there, and those clinical documentation specialists need to have specific characteristics and abilities. So what's your thought about that, and how do they come about?
Okay, that's a really great question. And that's come up quite a bit, because what is the background whenever you're looking for a CDI professional? There's not like a degree in documentation integrity, but what we typically see, there's 2 roles that fit really nicely into CDI, and that is our HIM professionals, especially those coming in from a coding background, because they understand the coding classification systems that's being used, and also nursing and physician backgrounds, because they have that clinical knowledge to really dive into scenarios. Now, whenever we first started in CDI, and it's still occurring to this day, you'll bring in new CDI professionals that maybe have not done it before. They've got this strong background in clinical or a strong background in coding, and then you got to fill that gap. So there is additional education out there available. Like with AHIMA, we have intro courses that can be broken out and focus on clinical and coding to help fill those gaps that you see. So that's what we've kind of done to fill, the gap there. If you see a CDI professional that has like their CDIP credential, then you know that that's a person that has the education, the background, and then they went through and they've done some work, because you have to have worked in CDI on some aspect before you can get their credential. So you know that they've had that additional hands-on experience to get them where they need to be. So those are kind of the two big backgrounds. But I have seen professionals come into CDI as respiratory therapists. And I had a CDI professional who was hired on and was a health educator, and they did phenomenal in the role. So I would caution you, don't just lock yourself in a box that you require this one degree. Really look at the person. Do they have that willingness to learn? Because you need ongoing education in CDI. Good communicator, because they're going to be working closely with physicians. And so look for those skills and then determine who your key candidates are. Does that answer your question? Okay. And I see a question in the back.
Good morning.
Morning.
Thanks for a nice presentation. My question is regarding this. Can you highlight more about this multiple choice queries? How can we raise this multiple choice queries?
Okay. Formatting a multiple choice query. Yes. So whenever you're looking at a multiple choice query, there's no limit. The query, the example that I had up there was a multiple choice query. So you're going to have your question that you're asking. And then the options, usually at the top, are going to be conditions that could possibly bring in that next level of specificity. Let's say you have a patient coming in with chronic kidney disease, and you want to identify the staging of that chronic kidney disease. You may bring in the GFR that's been identified in the health record, that we use that to help with the staging of CKD. On your options, that GFR may be borderline stage 3, stage 4. So in your options, you would probably put stage 3, stage 4, other explanation. You could put unable to determine, but if it's pretty straightforward, you don't have to put unable to determine. Those could be your 3 options right there: stage 3, stage 4, an other option. And we just updated the practice brief that there may be times where it's really clear of the staging. Maybe you have a patient coming in and they're on dialysis. Well, that's pretty well telling us that we've got some, end-stage renal disease. I think I've got a scenario about that here in a moment. So maybe your option is end-stage, stage 5 CKD, based on that GFR. Now, does that answer your question, or is there another element to the multiple choice query you're wondering about? Okay, wonderful. Okay, so I'm going to go ahead and dive into our next presentation, and then I'll try to have time to pause for some more questions. And if I don't get a chance, you can catch me at the break, or I can always hang around after the presentations today. I want to make sure we get all your questions answered. All right, can I back up a slide? How do I go backwards? This one? Okay. All right. So this one here, let's discuss a little bit of the value of CDI now that we've had a refresher on what CDI is. So to think about the value, you've got accurate data capture, payment accuracy, and cost reduction efforts. These are only a few. There are many more, but today we only have a few hours to spend together. And so we're going to focus on that top tier, which is that financial impact. So with our coded data, again, it can impact this reimbursement calculation, but a few others, as the CDI program matures and evolves, it can impact quality reporting. If you do report cards for physicians in the United States, we have several reports where we can look at healthcare organizations and the physicians themselves and see how well they're being, how well their quality measures are being captured. Documentation has a direct impact on that. Disease tracking and trending as well. Okay, so this is another scenario that I wanted to kind of walk you through. This is a patient with functional quadriplegia. It's a post-traumatic brain injury. They presented to the hospital with this chronic cellulitis to the left leg. It's getting worse. They've got redness, and they're on hemodialysis. Our attending physicians did an examination of the skin, see the redness. There's some purulent drainage. And so plastics is consulted, and they're going to do surgery for an excisional debridement. And so the plastic surgeon comes in, they've got a full thickness pressure ulcer, this left heel, they've got necrosis, they've got cellulitis. And so the attending comes in, they're talking about, they do the procedure, the redness is getting better, they're going to go home. And so, but there's a key documentation element here that we're missing, kind of back to, as I was talking about the multiple choice queries, we have a patient on hemodialysis, but we don't mention that condition. And I've got physicians who are like, well, I'm not bringing them in because they're, you know, struggling with their dialysis. They're not having an acute episode of the kidney failure. They're not in fluid overload. But if you're going to do surgery on a patient in end-stage renal disease, you're going to be pretty cautious. I mean, all the physicians that I've worked with and the nurses are pretty cautious on these patients. They can get sick really, really fast. And so we want to make sure that we capture that complexity. Now, this afternoon, I think Kylie's going to bring in some scenarios that'll have reimbursement based on your complexity scores, but I wanted to show you just the impact on this one. And most of these scenarios are brought in from some real cases that we've seen out there. So we can see bringing in, we sent a query, end-stage renal disease was then documented after the query. That DRG weight went from 1.1 to 2.8, and our length of stay went from 3 to 7 days. Reimbursement, and this is in dollars, went from a little over $6,000 to over $16,000 because of one condition. And so we see this occur frequently. Your CDI professionals, you want to make sure they have an efficient work process, because reviewing one record can bring in quite an impact financially to that case. One diagnosis. So quality measures, complications of care. Complications occur. We want to make sure whenever we're looking at the documentation, if it's unclear, if there's been a complication, they've had surgery, they went into respiratory failure. Did they go into respiratory failure as a complication from the procedure? Or they a COPD patient who then had an exacerbation, went into trouble, heart failure patient, they had respiratory failure. Really, it was something that was unavoidable. Documentation looks at those elements to make sure that it's clear if we had a complication or not. Medication errors. I have had my team of CDI professionals before I came to work for AHIMA. I managed 3 different CDI programs in acute hospitals. And so I have seen my team find medication written in on a health record that really didn't make any sense. So they're querying the physician to determine, is there a diagnosis here that hasn't been mentioned? And sometimes that's the case, but then sometimes it's accidentally been copied over from another case. And then you've got a medication error. So we find lots of things in CDI. So there's a direct impact to patient outcomes. And that goes to medical errors. And I'm going to bring in a scenario that my team ran into on the next slide. And then providing evidence-based care. So CDI professionals should be trained in the evidence-based information, clinical evidence, that current research. So they know what they're looking for whenever they're identifying the clinical evidence, as well as those diagnoses and procedures, services that's been documented in the health record. So this case here was an interesting one. This happened to my team. One of the CDI professionals was reviewing the documentation. Whenever she came across some documentation that was conflicting on which limb was going to be amputated later that afternoon. And so, I've read horror stories of facilities that have, made mistakes like this. And so whenever that was identified, the surgical team and the physician was alerted. The physician at that time verbally told the nurse on the floor which limb was going to be amputated, but the surgical team came up and they were like, no, this has to be very consistent. We have to update the documentation. So we called up the surgeon, did a review of everything that was documented. That way we validated which limb was going to be amputated. Then the surgery was performed successfully. Patient recovered without any complications. Now, hopefully that case, the surgeon was well aware of the limb that they were going to amputate. But if you've ever been part of a surgical team, does anybody have worked in surgery in here, been part in surgery? So if you're in that suite, it gets pretty busy. you've got a whole team that's prepping that patient. And so whenever the surgeon comes in, drapes are up, everything's prepped, everything's ready to go. And that's where, because they trust their team to prep the right limb to be amputated. So these are key opportunities that we've identified. And there's other scenarios that I've heard out there, but I wanted to bring in one to just show that direct impact, because we can make all the financial impact bringing in that complexity. But if you have a poor outcome, and then that reputation, your reputation for your facility is really tarnished, and you don't want that to happen. So you want everything in place to make sure that the care is as compliant as possible. So whenever we think about documentation, you want a consistent theme. I talk about this a lot. And in CDI, whenever we're doing training, we talk about looking at that diagnosis, look at the specificity. Have all the diagnoses been brought in? Are they specific as the evidence will support? If not, then if we're looking for an underlying cause, remember we look for that unknown etiology. Procedural specificity. Do we know the procedure? Was everything written in detail in that procedural report that we need to see? Usually with op notes, we don't find as much opportunity, but there are still opportunity in those operative notes. What you will see frequently in your procedures is sometimes the conditions, some complications of care, not complications of care, but like comorbid conditions will be missed and not brought in. And so you want to look very closely at all the procedural documentation. Assessments. Do the assessments match up with what's being documented in the health record? Again, in the age of the electronic health records, very easy to copy and paste. So if an assessment shows that that patient looks stable, but then sepsis is being documented, we need to do a little bit closer look on that and determine, because most sepsis patients, whenever the sepsis is active, they're not going to be that stable. Then the clinical evidence again matches the assessments. And then what's our treatment? Is there something documented that wasn't treated? We had a patient one time that was getting ready for discharge and was doing pretty well. And the physician came in, wrote the discharge order, but that was before the lab work had come in that morning. And the nurse was going in to then discharge the patient. But whenever the lab work came back, our CDI nurse, well, CDI professional, was up there, and they saw the lab work come in, and the creatinine, excuse me, the creatinine had jumped up. I'm gonna have to get a drink, excuse me. Okay, let's see if that's better. Okay, creatinine had jumped up, and it had been normal all the way throughout the stay. And this was a patient with several comorbid conditions, heart failure, COPD, definitely at risk. And so what happened was we went ahead and called the provider and talked to them about that creatinine, and they went ahead and diagnosed acute renal failure. Patient had to stay in a couple more days. But if that CDI professional had not come in, then that might have been missed. Now, that was one that we also did some peer-to-peer education about discharging patients before that lab work comes in. You want to make sure you're looking at everything thoroughly before you then write that discharge order. So technology, we talked about the queries. We talked about the compliant components of queries, but technology offers a lot of opportunity. And I wanted to bring that in because now this one right here, there's a lot of, available information out there. But this was reported from one of our clients, because we do some standard query templates to help guide the development, to ensure that they are being written compliantly, clearly, so the physician understands them. And so it helps streamline the process. And this client sent us in a report of their productivity. It was taking their CDI professional on average about 30 minutes to write up, do the review, get the queries sent, to get that query completely created. Because whenever you're creating the query, you go through and you review all the evidence. It takes some time. And especially if you're just writing it out from scratch. But they started using templates that helped guide them into the opportunities they should be looking for. And it had multiple choice options already embedded, so they could just remove any options that weren't applicable to that scenario. And so it took them from 30 minutes to 5 minutes to then write a query. So you want to make sure and look at what's available to you, because then you can help streamline processes. And you remember that case I mentioned a little while back, where we brought in over $10,000 on a case for one diagnosis. If you get a CDI professional who's well experienced in CDI, they may be able to review a case in 15, 20 minutes. If you just save them 30 minutes, then, I mean, you're adding a case or so on that they're reviewing. That can add up very quickly on the financial impact that you have for your facility. So those impact areas is that accurate diagnosis capture. I've talked a lot about that, so I won't dive into that in much more detail. Coding to that highest level of specificity. And you want to make sure you have timely billing. Whenever you're sending out a bill, you want that health record to be complete. And that's one thing that your CDI professionals help you do. They're looking for that complete health record. They're supporting the physicians, the coding professionals. Now, there are some programs that have coding professionals that are actually doing part of CDI, so the structures may vary a little bit, but the goal is to ensure the documentation is there and you can get that bill dropped in a timely manner, because you want to be able to get that reimbursement in. And then the appropriate reimbursement, talked a lot about that. And then the reduction in denied claims. So I wanted to bring that in. I don't know if you guys deal a lot with denied claims, but as we focus on pay for performance, one thing that we have noticed is that whenever the health record is reviewed for payment from our payer source, they may notice discrepancies. They're also, they may employ CDI professionals who are trained to look through and determine, are all of these conditions really supported within the health record? And so you want to make sure that the documentation is complete. You won't have as many denied claims if they are doing those reviewed. If you ever deal with a denied claim, it can be very time consuming in going through and determining if it was, if you agree with the denial. And so that's another important point. Let me pause here for, have I got 5 minutes for questions, or do we need to hand it over? Okay, do we have 5 minutes is what I've got left, probably one or so question.
Hi, good morning.
Good morning.
Thank you for the informative lecture. Now, as you talked about the 30 minutes which needed for the CDI to finish up from his review with the file, do we have any kind of, let's say, an equation to calculate the productivity of the CDI as we are preparing our workforce plan? So we don't know, shall we have like 1 hour, or it depends on the expertise of the people who are working there in the department?
There are several variables that come into play. That question has been asked before. It's a really great question. We've never been able to come out with one equation per se, but what we see result best is to do samples of the areas that you're going to start in, and then start to do an average of the time it's going to take within that area to help you determine the number of CDI professionals that you would need in that area. And, if you touch base with me after, I can provide some more information. We do have some equations on what that would look like. It is a little complex because you have to take so many variables into consideration. So let's say you are starting a CDI program in a medical unit and also in the intensive care unit. Well, on the medical unit, those patients are going to be less complex. You're going to be able to review that health record much faster. ICU, more complex, consulting notes coming in, more time consuming, sicker patients. And so from my experience, I always did a sample study before I determined my productivity expectations for that floor. And then after I would do the pilot study and would determine, okay, well, here's what we're going to do. Here's how many CDI professionals I'm going to put up there. You also need to identify, if you're going to be looking at all the health records, every patient, or if there's a certain population that you're going to be looking for. If you decide on that population, then you have to have the technology or something in place to help you identify those patients. But then after you identify that location, the population that you're going to use, then follow up 30 days and 90 days after to see if they're meeting those productivity scores. If they are, then you've probably got a pretty good level that you're trying to achieve. If not, then there may need to be adjustments. So productivity is hard. It's a little challenging. It takes a little bit of time to get it just right. But if you take the time and do a sample study and come up with a realistic plan, it pays off in the long run because then you have a more efficient team overall. Does that answer your question? Yes, yes, same concept in outpatient. Usually in outpatient, you'll see more records. They'll be able to look through more of them, but it's the same concept that you would apply in outpatient. Absolutely. Okay. And I think I'm about at time. And so I'm going to hand it over to, okay, I'm going to hand it over to Ellie. Thank you.
Thank you, Tammy. Thank you very much, Tammy, for your time. I think you have a well-deserved break now. Next will be Mrs. Manal Al Khalifa, Director, Policy Engagement, Clinical Coding at the National Case Mix Center of Excellence. Mrs. Manal راح تحكينا عن الترانسفورميشن والتوجه المستقبلي بالمملكة. So I will pass the mic to her. أهلا وسهلا فيكي.
Assalamu alaikum, صباح الخير. Good morning, ladies and gentlemen. It's a great pleasure being here among all of you. I would like to thank KNWBILITY for the invite and for the opportunity to present the National Case Mix Center of Excellence and our direction regarding the clinical documentation integrity in the kingdom. My name is Manal Khalifa. I'm the Director of Policy and Engagement, and I'm also the Deputy of the Executive Director of the Center. So I would like to start my presentation with a brief about the healthcare transformation, which I know all of you know much more than me, but I thought it's a good starting point for my presentation, and it will be a good segue to our role in the health ecosystem. So since 2016, all of you have witnessed a lot of reforms and transformation in different governmental sectors, and one of the important sectors is the healthcare sector. So our health care sector was transforming in alignment with some global objectives, which is multidimensional and focuses on prevention. It also focuses on integration of care and continuity of care. It also, we describe it as person-centered or community-centered. It allows for innovation. It also allows for the advancement in technology. And most importantly, all the direction is towards value-based healthcare and value-based financing. And Tammy thankfully talked about the value-based and Tam, I think. So also this slide, I know you all know it by heart, but I believe one of the cornerstone of the transformation or the healthcare transformation is the separation of the three roles of MOH, the separation of the regulatory role from service provision and from healthcare financing. And we've noticed a new emerging key entities in the health ecosystem, such as the health holding company, which is responsible about corporatizing the providers and reforming the service delivery, and also the Center for National Health Insurance, which is responsible about reforming the healthcare financing and the payment mechanisms. So I mentioned the reforms in service delivery and funding mechanism or payment mechanism, which are really critical to achieve the transformational goal of value-based healthcare, which is payment will be based on the number and type of patients and also the delivered outcomes. There will be a need to measure cost at different levels, this to support more efficient and cost-effective care. Also, there will be a need to measure activities and clinical variations of care at different levels as well to support high quality and better outcomes. And finally, this will enable us to track overutilization of services. This will support the prevention and the health promotion efforts. So in order for providers to achieve the value or to be ready, at least for value-based financing, I think they need to focus on 4 main domains. These domains are the people, governance, systems and resources, and finally the data. Regarding people, this list is not exhaustive, but again, in order for providers to be ready for value-based financing, they need to have qualified clinical coders, qualified clinical costing specialists, qualified clinical documentation specialists, as well as case mix specialists, of course, data analysts and actuaries. In terms of governance, there should be strategies at different levels. There should be policies and procedures, guidelines and frameworks. Of course, technology is the enabler, and we have a lot of advancement in technology. So providers need to have their own tools and resources and their continuous development and improvement. All these 3 domains will enable the providers to produce the required data for measuring outcomes or to achieve the value-based care and value-based financing. So this data need to be standardized, coded, and classified. And we cannot have standardized, coded, classified data without having a complete, reliable, accurate, timely clinical documentation. So clinical documentation is the very first step of the whole transformation to achieve the value. And it is the single source of truth. If we have a high quality clinical documentation, this will result in high quality coded data. This means accurate assignment of DRG, accurate costing, and of course, this will enable us to measure the outcomes and achieve the value. So who are we? As I mentioned, there are new entities emerged with the transformation, such as the Center for National Health Insurance, the National Center for, Center of Excellence, Case Mix Center of Excellence is one of 3 Center of Excellence incubated currently in the CNHI, the Center for National Health Insurance. So our vision is to be recognized as a world-class leaders in the case mix concept. And I think there are very few examples around the world of case mix centers. Our mission is to accelerate quality healthcare delivery and efficiency by promoting transparency, and transparency is our golden word, through the effective use of clinical coding, patient classification, and clinical costing to achieve sustainable value-based financing. Our values: collaboration, excellence, innovation, and transparency. So there was a strategic requirement to bridge the gap in the building blocks of the funding reform. And that's why the Case Mix Center is established. So these building blocks, I call them here the case mix building blocks. They are the clinical coding, clinical classification, clinical costing, national reporting, health research evaluation and benchmarking, national policies, and funding mechanism. And the clinical documentation is in the center. It's the very first step to achieve this whole cycle. And these building blocks are reflected in our organizational structure. So we have a department for coding and classification. We have a department for clinical costing, health economics and modeling, policy and engagement, and finally, actuarial governance. So what's our relation to CDI? We do realize the challenges in the kingdom in terms of clinical documentation integrity or improvement, such as the lack of governance at different levels, from the national level to the provider level, the lack of tools and resources, lack of specialized personnel, lack of training and guidance, lack of career path, accreditations, and incentives. So I know there are a lot of efforts happened during the past few years. This timeline or this list is not exhaustive. I know there are several initiatives for training, several CDI camps happened, and recently one of MECCAN programs has launched to train CDSs and the clusters. But I wanted to say that in 2018, the health holding company did the first baseline assessment to identify the gaps in terms of workforce and infrastructure. And they proposed some initiatives to be implemented in the clusters. And then in 2019, the CNHI did the first pilot to do a clinical documentation quality assessment. And in 2020, they started actually the first clinical documentation quality assessment, and the scope is expanding year after. So now we into theory. So I promise you, during this year, 2023, we have several initiatives that are related to the CDI, starting from developing the National Health Information Management Governance. We will be also developing the clinical documentation quality guidelines, the clinical coding and clinical documentation workforce strategy, clinical coding quality guidelines, clinical coding query guidelines, and finally, the clinical coders and clinical documentation specialists awarding system at the national level. So I'll conclude with this slide. We have an ambitious target for the national data reporting. By 2027, we will have 100% coded and submitted patient activities in MOH provided with 90% accuracy. And by 2030, we will have 100% coded and submitted patient activities in other governmental providers with more than 90% accuracy. And we cannot achieve these two ambitious targets without having a 100% complete and accurate clinical documentation. Thank you.
شكرا لك منال. Any questions for Manal?
These two challenges you mentioned about the clinicians. We have two main challenges: the skill that the clinician they never learn about the high quality clinical documentation during their university studies, even postgraduate continuous education. Many of them they didn't receive any of this educational activity, so they lack the skill of the high quality documentation. The second challenge after the skill is the culture itself. Most of the clinicians, they don't realize the importance of this high quality, and they don't care about it. They don't realize the impact that comes on the research, on the finance, on the reimbursement, in the quality measures, all of the impact that you mentioned earlier. So you mentioned how you can tackle these two challenges on the national level, but on the hospital level, how the hospital can tackle these two challenges?
Yeah. So two parts, the technical skills part and the culture and awareness. So I think the first point for us is to develop the strategy at the national level, and it should include the strategies at all levels until reaching to the provider level. And once we have the strategy, we start changing the culture and spreading the awareness. And regarding the training, I know, as I mentioned, there is one of MECAN programs already started, the Saudi Commission for Health Specialties, to train CDSs in the clusters. But we do realize that this is a national need, and we need it to be as a national program for everyone, of course, with some criteria, and we could link it to licenses to be accredited by the Saudi Commission for Health Specialties, because we do realize this need at the national level. I hope. Once we have the strategy, we will implement the strategy. We do take the responsibility of awareness with other stakeholders, like the holdco and other stakeholders in the system. And we will do several workshops and awareness to help you upskill your personnel. Any other question? Thank you so much.
حقيقة إذا بتسمحوا لي أنا كمان حابب أعقب على السؤال اللي تفضلت فيه حضرتك. نحن كأكاديمية مع شركائنا بأهيما اشتغلنا مع التجمع الصحي بالمنطقة الشرقية، التجمع الأول، ومشينا بهالترانسفورميشن سوا. بعطيكم الإكزامبل لأنه بيساعد بكيف فينا نحقق التحول بمجال التوثيق السريري. أولاً مثلاً أسسنا إدارة التوثيق السريري بالتجمع، حطينا الهيكل التنظيمي مع الوظائف والإدارات اللي فيه أو الدوائر تحت الإدارة، حطينا السياسات والإجراءات لهاي الإدارة، وحطينا التول كيتس والتمبليتس اللي بيستعملوها بتقاريرهم اليومية. المرحلة الثانية كانت اللي تفضلت فيها كمان حضرتك بالسؤال التشينج مانجمنت، يعني الكالتشرال سايد اوف امبلمنتيشن. عملنا تشينج مانجمنت بلان واويرنس بلان، حطينا الاستراتيجيه، حتى حطينا لهم التمبليتس والصور اللي ممكن يطلعوها بالايميلات بالبانرز بكل هالامور بالنيوزلترز، وتم تطبيقها لنشر وعي اهميه التوثيق السريري بالحياه اليوميه للتجمع من اليوم ورايح. بعدين فتنا بمرحله التدريب، دربنا دكاترة على الكلينيكال دوكيومنتيشن ليصيروا بحياتهم اليومية تتحسن نوعية التوثيق. دربنا فريق متخصص رح يصيروا هن يتركوا مهنتهم اليومية إن كانت بالطب أو التمريض أو المساعدة الإكلينيكية، صاروا موظفين دائمين داخل إدارة التوثيق السريري. أخذوا تدريب خاص من عنا مع شركائنا بأهيما اللي هي الشهادة اللي سمعتوا عنها CDI. وهيدي يعني بدها دراسه حدود 3 شهور سوا اكيد، لان احنا بنجيب مدربين يدربون مش بس الدراسه لحالهم اونلاين، وساعتها بيصيروا equipped ليكونوا هن الاخصائيين للمستقبل بمجال التوثيق السريري، اللي مثل ما شفتوا الكيس ستاديز هن رح يروحوا يحكوا الدكاتره ويتاكدوا من التوثيق وياكدوا انه الكومبلكسيتي او severity كل هالامور هاي reflected for better implementation of the RG وبعدين الانشورنس. صحيح، لانه كمان كان عندنا مرحله رابعه عملنا مثل CDI Champions. هول دكاتره بعدهم على راس عملهم بالرعايه الصحيه، ما بيروحوا على اداره التوثيق السريري، ولكن هن بيكونوا مثل سفراء التوثيق السريري، كل واحد ضمن اختصاصه او المستشفى اللي هو فيها، وبيساعدنا بنشر التوعيه ودعم التحول داخل التجمع. وبالاخر اكيد كله بيحصل على الشهادات المعتمده من أهيما. فحبيت اعطيكم هالمثال لانه تطبق على الارض. اذا بتحبوا تفاصيل اكثر فينا نحكي فيها بالبريك. وبلشوا شغلوا حتى من بعد ما خلص التدريب والتاسيس، يعني كمان اعطيناهم فتره بعدها ongoing اللي هي مثل المنتورشيب بروجرام. كل اسبوع بنجتمع سوا، بنشوف شو هي الكيسز اللي عم بيشوفوها، اذا عندهم اي استفسارات and so on. يعني كمان مثل انه بنمسك لهم ايدهم على فتره معينه بعد التدريب لنأكد انه اللي دربناه عم يتطبق وعم ياخذوا البنفيت المطلوبه. في اي سؤال ثاني على الاجزاء اللي تغطت اليوم بالفتره الصباحيه؟ I'll switch to English. I think now because the next part we plan to do it after lunch. Maybe we can have our prayer break and lunch break earlier than planned. And if we can come back at 1:15, please. So that's an hour and a half break بين الصلاة والغداء. ولكن لو سمحتوا بليز تأكدوا إنه سجلتوا أسماءكم ومعلوماتكم بورقة الحضور، لأنه هاي اللي على أساسها راح نطلع شهادة الحضور لورشة العمل اليوم. اللي ما سجل اسمه في ورقة هون موجودة على الطاولة النصانية، لو سمحتوا تسجلوا المعلومات لنقدر نرسلكم كمان الشهادة. أوكي، شكرا لكم، ومنشوفكم على الساعة 1:15 شارب لو سمحتوا. شكرا جميعا، أهلا وسهلا فيكم. إن شاء الله البريك كانت مريحة. رح نرجع نبدأ إن شاء الله بكمالة نهارنا وورشة العمل سوا. بحب رحب بضيفنا أستاذ مشبب العسيري، مدير إدارة السجلات الطبية والمعلومات الصحية بوزارة الصحة. أستاذ مشبب، إذا ممكن تشرفنا. أهلا وسهلا فيك.
السلام عليكم ورحمة الله وبركاته، حياكم الله جميعا، وكانت فرصة سعيدة بمقابلتكم وحضوركم. نشكر الشركة المقدمة على هذا البرنامج، وكان الهدف في مقابلتنا اليوم أول شيء لنا فترة طويلة ما شفناكم. النقطة الثانية لازم يعني أنتم كقياديين تتعرفون على أكثر من أوبشن في المستقبل القادم كتجمعات، إنه لك عدة خيارات في اختيار المسار الصحيح الذي ممكن إنه يساهم في عملية يعني نجاح المكان اللي أنت فيه هو المنشأة الصحية. يعني نحب نشكركم جميعا على الحضور، ونعتذر من التقصير، ونتأسف عدم حضورنا اليوم الصباح بسبب يعني اجتماعات طارئة أدت إلى تأخيرنا، وحياكم الله جميعا.
أهلا وسهلا فيك. طيب، مثل ما وعدناكم، الجزئية الثانية من نهارنا اليوم رح نكمل we'll continue with Tammy on the practices. Kylie first. Okay, sorry, there's been a mix-up. Yes. Sorry. So we need to change the slides. Okay, I'll hand over to my colleague, Kylie Axford, Senior Consultant Training at Nobility. I'd also like to introduce my colleague, Noor, if you can come for a few minutes. Noor Al-Basri is one of our trainers in the Riyadh office. Noor works closely with Kylie on medical coding and also clinical documentation in our training projects with our hospitals. أهلا وسهلا فيكم.
Thank you very much, Mr. Ali. So good afternoon, everyone. So thank you for coming back after lunch. We're going to continue the theme of transformation, but I want to give you next steps. So we talked about transformation. Ms. Manal, mashallah, talked about the strategies where we need to go. So what we wanted to do is give you an idea where you can actually make a start on your next steps. So what can you do to assess where you are right at this moment? Okay, so we have a look. So the purpose of the clinical program, clinical documentation improvement program, and yes, we will move to an integrity program, but first we need to improve. Okay, so it's a critical function of your healthcare because it updates and changes and gives you your expectations of your outcomes. So when we're talking about expected outcomes, we're talking about your financial, so your revenue cycle. So we know that our CDI is going to impact on our decision-making, our financial, our safety, our quality, all of these kind of things. So it's an important thing to do as a critical function for our population and risk stratified populations. So it's a requirement for now I get this right, the National Health Insurance. There's a C, I can't remember what the C stands for. National Health Insurance and the Accountable Care Organisation playbooks. So it's part of what you need to be doing. It's actually part of your playbook. So it's important that we do this in order to successfully implement these new financial and payment models. Okay, so yes, I'm going to talk money. It's not the only thing I will talk. It's important as a foundation for every health record. You're already doing this. You're already documenting. What we want to do is encourage you to to be very deliberate about your documentation, to train your doctors to be deliberate about their documentation so that they're not actually doing more work. They're doing the same amount of work, but we're getting better outcomes. Or even better, we get less work, better outcomes. Okay, it's the core of every patient encounter. So they're, like I said, they're already doing this. We're not asking them to do anything new. We're just going to teach them and train them to be more specific and more efficient in what they do in order to get these better outcomes. Okay, so again, as Ms. Tammy mentioned, we must be clear, consistent, complete, precise, reliable, timely, and it must be legible. It must make sense. Okay, and that will reflect then our patient's burden, disease burden. It will reflect the complexity of the care and the treatments that we're providing. Okay, so this is what we're looking for. And also too, it identifies compliance with our national measures. So that is also part of what we're trying to achieve. Okay, so what do we do about identifying the gaps? Okay, there was a study done by Becker's Healthcare. They looked at 60,000 inpatient records in the US between 2020, 2022, and they found in the US with CDI programs that have been running a long time, still getting 46 to 60% of inpatient records are missing documentation. So there's a long journey ahead of us. It's not an instant fix. It's a continuous development. It's a long journey ahead. So what we're trying to do is the fact that this impacts on the leadership's decisions. How does leadership decide how many staff to employ? Do we have money for salaries next month? When we have to actually do accountable care and accountable costing and funding, we need to know what our revenue will be. We need to know how we do this. And how do we make those decisions if the data we have is incorrect? And this is what we're doing now. With our incorrect data, we're making decisions. So the better we improve our documentation, we improve our data, we make better decisions, which then just continues to snowball. So the accuracy of the record plays a key role in providing the best clinical service. If your documentation is accurate, if you're giving specific information in the record, then your younger, more junior doctors are not guessing what the senior doctors are thinking. They know. They're not in 2 a.m. in the morning changing a care. They're not doing something that actually contraindicates what's happening during the daytime and actually reversing your patient's condition. Okay, so it's important that we actually get this documentation because it also forms a training tool for our junior doctors. Okay, the documentation is a prime source of education for our doctors. So we need to do that. Okay, we know it's difficult, especially in demanding environments. So we know it's very difficult for the documentation to have the time in these demanding environments. But without the support of a structured CDI program, it's almost impossible. We're not going to get any change unless we put some structure behind them to support what we're trying to achieve. So that's what we're looking for, okay? And the way we do this is through our CDS specialists, so the CDI's trained staff that do the reviews, and through our champions. And our champions are our physicians who have a vested interest and a focus and a passion for what we're trying to achieve with documentation. Okay? And they're an essential tool. You won't get your success if you don't have buy-in from your clinicians. Okay, so what is the roles? The CDS goal is to review the record, supporting and educating providers how to document fully within the record. So not only reviewing and sending queries, but educating physicians so that they don't have to resend the same query over and over again. Okay, so it's more than just review. It is also an education role. Okay, so for example, we'll use in Saudi Arabia, diabetes unspecified. If we queried every diabetes unspecified, the doctors would have no time to see patients. But that's an education opportunity. That is a simple education opportunity that can become part of your program. And then you're not sending queries for those until you're still having non-compliant physicians. Okay, so it's important. They have provide the specificity, the technical knowledge. They're the ones reviewing the record. Our physician champions, like I said, are our healthcare provider who champion CDI, who lead by example who are a point of contact for physicians who are asking what's going on, what's this about, why should I be engaged? They're also a source of expert clinical advice to the CDS specialists, to the CDI specialists. So they're kind of our bridge, I guess, between the physicians and the clinical staff to the CDSs, and the CDSs are also a bridge between the clinical staff and the coding. But they provide a great resource, and they lead by example. So they provide that support to the physicians, and without CDI champions, it becomes more difficult to get your cultural buy-in. You can't get your physicians to join in. They need to follow and see other people doing. And we all know that doctors are competitive. So if somebody's wearing a champion, the other doctors want to be champions too. Okay, so the goals of our program, we're looking for clinical accuracy. So yes, we're looking for revenue, yes, we're looking for these things, but our primary goal is clinical accuracy, the clinical truth of what's happening. What are we treating? Why are we treating it? And how did we get there? So we're looking for that clinical accuracy. We want to optimize the case mix index, and I'll show you case mix index and what that means in the next presentation on. We want to make sure we're getting the correct DRG, so the diagnosis related group, because this is how we're working with our funding models at the moment with the DRG. We want to make sure that we're getting a record of the correct severity of illness. And in the Australian and the Saudi context, that's your diagnostic complexity levels and your episode complexity levels. We want to look at the risk of mortality. And in the AM context and what you're using now, that's called your Charlson score. We'll show you your risk of mortality, the chance of dying within 12 months. We want to look at demonstrating the quality of our care. The physicians provide amazing care, but there's no evidence. There's no proof. If you don't write it down, how can we prove it? Okay, we want to look at things like any adverse events, complications, because we cannot fix problems if we don't know about them. So if we're having medication errors, we can't fix the workflow processes that are causing these medication errors if we don't know about them. And we won't know about them if we don't document them. So this is where we talk about this. We will talk about things that are national reporting. So those things that are required by the Saudi Patient Safety Centre for national reporting, things required by Sabahi, the Ministry of Health, for reporting. We want to make sure they're documented well. Okay. Obviously, we want to minimize any insurance rejections and denials because we do need to have money to operate. And we want to make sure we standardize our data so that we can actually research and develop. And obviously, the last thing on the list is a legal defense. So we often hear us talk about if it wasn't documented, it wasn't done and it can't be coded. But to be more specific, if it's not documented, the physician can't defend themselves, the hospital doesn't get paid, nobody gets holidays, nobody gets a salary, and it can't be coded. And there's a lot of other things that come through if it's not documented. So it has a much bigger, broad impact across the facility. So we need to make sure that we're getting our documentation in there. Coding is an end result of that, but there's other things that go into that record that we need to be focused and looking at as well. And I think Ms. Tammy will cover a lot of these in the quality measures. So our key steps to a CDI program, we need to do a needs assessment. So we need to look at where we are today. What do we need to do? Where do we need to focus? We do some audits of charts and we do a review of the documentation. We'll analyze and report our results with our recommendations for areas for improvement. Where do we want to target first? Obviously, we cannot target every record in the hospital. We don't have sufficient staff. There's just not enough. So we need to be very strategic on where we start. We obviously want to engage our physicians and clinicians to make our movement and make our change. And then obviously we want to continue this process of evaluation as a quality tool. So we evaluate and manage and continue these needs assessments and reviews so we can see how we're improving and where we may need to change strategy. So it's an ongoing process. So the first part is, again, like I said, the needs assessment. So we're going to look at our most common high-risk diagnoses. Now, this will be different depending on your facility, what that will be. But you're going to look at things like has a longer than expected length of stay. You have a patient come in with, I don't know, appendectomy, and they're there for 15 days. Why? Appendicitis, appendectomy, 15 days? Doesn't make any sense. There has to be something going on. So we're going to target those things that are longer than we expect because we're missing complications. Okay, we're going to look at those lower than expected lengths of stays because maybe the coders are overcoding. Okay, and that's going to become an issue because they're going to say, well, your coders are overcoding. That's technically fraud, especially when we start looking at this as a funding model. So we need to look at those as well to see whether there's coding gaps or where the education needs to go. We obviously want to make sure where we have a principal diagnosis that maybe is a symptom code. So chest pain is a symptom. It's not a diagnosis. So we want to look at any of those to see why do we not have a diagnostic statement? Why do we not actually have a diagnosis? We want to look at some of our complex cases that are high cost. So not necessarily high payment, but high cost. So you think your orthopedics, your hip and knees, okay, they are very expensive. Just the prosthetic itself is expensive. So you want to look at those high cost cases, your transplants, those things, they're high cost. You want to have a look at anything that requires specificity. So I already mentioned diabetes, okay? Diabetes is a major problem for the kingdom. We want to be specific. We want to know more information, and we cannot do anything to improve and do the health promotion if we don't have the data. Okay. We want to look where there's national regulator requirements. So I mentioned the Saudi Patient Safety Center has national reporting requirements. The coders actually code these things as well. And if you're reporting to, if the coders are capturing it and it's not being reported to the Saudi patient, there's obviously conflict in the information. So we want to make sure that this is being captured as well. And then again, our strict coding standards. So when you look at the coding standards that the coders work under, they have very strict standards. One of the big parts for them is if it's not documented as a diagnosis, they cannot diagnose. So if you don't give them a diagnosis, they can't code it. They can see all the clinical indicators. They can see everything that implies a diagnosis. They can't do anything about it except send a query. The next part of this is obviously then to medical record chart audit. So picking from there where you want to target. So obviously you're not going to try and audit every record. You pick from where you want to target your focus your target, and you review the provider's documentation for the diagnostic statements. Okay, so do you have clinical indicators with no diagnostic statement? Okay, which is the most common. The indicators are there. There's just no documentation of the clinicians or providers' interpretation of those indicators. That's what we need documented. Okay, so you're going to look at any relevant comorbidities. So if you're talking diabetes again, you're going to be looking for those common comorbidities, because once they're documented, then they're coded. Okay, so it's important, and that gives you your complexity of your diabetic patient. Okay, you want to look for the evidence of medical necessity, and this will come in with the insurance. If there's no evidence of medical necessity, no money. Okay, so you want to look at for any evidence of medical necessity. So do we have treatments without diagnoses? Do we have treatments and diagnoses, but no evidence of clinical indicators, nothing that proves that this is true? We want to look for obviously gaps or missing or incomplete or non-specifics. And then we want to look at any disparity between physicians. So is the consultant saying one thing? Is the attending saying something else? Has ED said something completely different? Is dietetics saying something completely different? Where are we going? So we want that consistency. Okay. The other things that you could look at through this is more on a retrospective and looking at the coders, is having a look at any coding discrepancies. So looking at the coding and saying, well, you know, are the coders missing? The documentation's there, but the coders are missing. And then this becomes an opportunity for the CDIs to educate the coders. Okay, so that they are not generating query after query to the physicians when the information is there, but the coders are not sure where to find it. So this is another role that the CDS perform. Okay, Accuracy of the field. So are they choosing the most specific with the information they're provided? So we want to have a look at those. Obviously, the appropriateness of the diagnosis and the comorbidities, and then making sure we capture any mandatory or combination codes. So if we have an infection and we have multiple drug resistance, we're capturing the multiple drug resistance. The physician is stating we have drug resistance, not looking at a path and seeing that there's, resistance, but did we change care? Do we actually have to do something different because of resistance? So making sure we're getting these combination codes captured. So can you imagine resistance will add to your length of stay? We also want to look at reporting. So once we've done our chart review, we've done our needs assessment, we've done our chart review, we need to obviously interpret what we find. So we're going to do our report. Okay, so we're going to look where there's opportunities for improvement. Now, this can be by specialty, this can be by ward, this can be inpatient, outpatient, prospective, if you want to do prospective review, concurrent reviews, retrospective, so post-discharge. There's all sorts of times when you can work this through. You want to have a look at any areas that identify a change to the case mix, okay, and where it impacts on your quality measures that you're capturing. So some of the things you'll be looking at is the severity of illness and risk of mortality scores. So are we getting a true accurate reflection of those? So are we getting at severity of illness? Are we capturing the conditions that require more specificity, more documentation? Okay, how many queries are we issuing? There's hospitals that have a 10 queries a month limit in the kingdom. That's what they've been told, no more than 10 a month. We don't want to upset the doctors. Okay, so, do we need to assess this? Are we looking at our response rate? So when we ask their inquiries, are the physicians responding? And if they're not responding, is it because they don't have the information and the education, or are we not querying them appropriately? So why are they not responding? We want to look at which clinicians are getting the most queries because they're opportunities for education. Okay, we want to look at a patient care area that's most often queried. So is it outpatients? Is it your diabetic clinic? Who's getting the most queries? And again, education. We want to do at the activity, obviously, of the CDIs or the people doing the queries. We look at the case mix. We look at agreement rates, response times. Do they respond in 24 hours, 48 hours, 3 weeks later? When are we getting our responses? Are we getting responses? And then obviously at the bottom, the revenue impact and DRG change. Okay. Unfortunately, that's what drives most of us at the moment is the revenue, but I put it at the bottom. And then obviously any documentation habit changes. So if you are getting a physician who you've queried, you've provided education, and he has made changes and his now query rates are dropping, some form of acknowledgement for that physician for the fantastic work that he's doing. Make it public. So we want to do things like this is, when we're getting a positive result, rewarding it. So again, this steps into the engagement and education. So this is what we do. Now we've got our report. We want to take this back to the physicians so that we can help them fall in line with what we're trying to achieve. Okay, so we'll do this. So we make sure we have them involved right from the start. We want to identify that the program has trained staff so that we're not alienating our physicians by having staff that don't understand the process, that have very clear policy, very clear structure. They know what they have to do and the workflows, and the physicians also know those workflows. So when we talk about that, we might talk escalation policy. So if you don't respond, what do I do next? Okay, and if you don't respond after 72 hours, do I take it to the CMO? And if you still don't respond to the CMO, do I make the file delinquent, which means no holidays, no salary? We need a policy. I know it's a bit harsh, isn't it? No holidays, no salary. So we want to make sure we're getting this documentation. We can use this documentation and the information we gather when we're doing queries, because we can now compare physician to physician because we have standardized data. standardized documentation. Okay, and this takes us again to the need for streamlining and improving our practices to ensure we get an accurate and complete clinical record, okay, in order to go to Vision 2030 and value-based care. Okay, so that's that part of it. Tammy, thank you very much. So, has anyone any questions about the kind of process? The slides are available from my understanding, but any questions about that kind of steps? Like I said, it's just a brief, an idea where to start. Yeah, just let's get started. Don't wait. Okay. Thank you. Thank you. Yes. Thank you.
Yeah, she's gonna, Kylie will bring in several case studies after we talk about some best practices here that shows some movement in the case mix. So I think that'll be very interesting to you. So I hope everybody had a great lunch. Happy to be back with you. Now we're going to talk about some best practices in CDI. These are going to be a few of the best practices that we see out there. That's it. No, that's the future. Hold on. It says best practices on the slide. That one. Thank you. Okay, so let's dive into some of the best practices that we see out there and look at some ways to monitor physician engagement. Kylie was talking about the importance of physician engagement, physician champions. And so we're going to discuss that a little bit too, and how you might be able to monitor that level of engagement. So a few of these that I wanted to talk about. First of all, quality audits. We discussed a little bit about audits, but you can do audits on the team, the CDI team, once you get them up and going and they're reviewing health records. One thing that we see a lot are second level reviews to look for any missed documentation opportunities. This may be, depending on the size of your program, if you're just now starting a program, it may be the leader of the CDI program. You may have it set up where you have a lead CDI professional if you've hired someone with experience, but someone that can go in and do a review of some of the health records that were actually reviewed by your CDI professional, looking for any of those missed opportunities. Now, a second level review doesn't necessarily mean we want it to be punitive. We're not trying to punish somebody for missing a documentation opportunity, especially when they're just starting in CDI. These can be educational opportunities. You missed an opportunity here and here. So, this is something to be on the lookout whenever you're reviewing the health record. So second level reviews can be very beneficial, especially whenever you're getting started. Once the program is mature, everybody's doing a great job identifying those opportunities, sending those compliant queries. It's still good to do quality reviews because it keeps everybody on the same page. At one hospital I worked at, we grew into a pretty large CDI program. We were doing really well. And so we actually hired two educators. That's what they did. They educated the physicians. Kylie was referencing that, the importance of having that educational component. They would also educate the coding professionals and the CDI team. They were a great bridge to get the transparency across the needs of all of those practice areas. So there's lots of opportunity, quality reviews with the second level. Take a look at that health records beneficial. Review a sample of the queries that were sent. You can do this internally, again, with one of your seasoned CDI professionals, your educator, your trainer. There's also services out there. Even at AHIMA, we do assessments on compliant queries for programs just to, take a look. How are they being written? Are they clear and concise? And it just helps get the team where they need to be. You want consistency across the queries that are being sent. You want to have some type of, you don't have to use query templates, but they're very beneficial in that structure. They're seeing the same format that comes through. So lots of things to think about whenever we're talking about our queries, and we want them to be compliant. I can remember having new CDI professionals coming on board, or even after we started implementing some of the technology with CDI, you can pull all this information from the health record. And I remember seeing one query that was like 3 pages long. My rule of thumb is I don't even want it to be over half a page, maybe 3/4 of a page. If, if there's a lot of evidence, clinical information that you're bringing in, they need to be clear and concise. So productivity standards, you want to focus on those key performance indicators. I don't have time today to really dive into all of those key performance indicators. I mentioned this earlier that we do have a practice brief, and I think there's a link in the slides whenever we send those out to that publication that really walks through a lot of the KPIs that you want to be looking for. Just to talk about a few of those, like your review rate. Whenever you start your program and you are determining how many health records you want your CDI professional to take a look at. As Kylie mentioned, maybe you can't look at all of those health records. With technology, that's helping a lot. But if you've only got 1 or 2 CDI professionals and you're a larger healthcare organization, they're not going to be able to look at, all of them. So you're going to pick a rate. How many can they look at? And then are they looking at the number that was assigned to them? What is that query rate? How many queries are you sending? And there's a lot of information you can gain from the query rate. And then internal audits as well, from the overall process and taking a look at everything within the program. You can do that internally if you have the structure to do that. There are external organizations that can do those audits as well, because once you spend the time and the money to train everybody, you want to make sure that you are functioning well, and having the outcomes that you want to see, and you continue growing. As CDI programs that I've started a couple where we were pretty small, but we saw such a great impact. I mean, we were bringing in better revenue, better quality measures. We grew into different areas, brought in more staff. Then we had the revenue to bring in technology to help us with that. So there's a lot of opportunity within CDI. So these audits, these assessments are important, in my opinion. Now, if you're going to do an internal audit, this is just an example of a rubric that could be used. So let's say that we're looking at, you're giving a numeric value. So you're finding a way to measure how compliant. So you're taking that unstructured information within the health record and you're reviewing it. You're doing that second level review. And then you're finding a way to make that into quantitative information that you can then report out on. So you're doing this record review audit, and then you're going through and how many missed opportunities were there, 1, 2, or 3, and you're giving them a score. And same thing with the compliant query audit. Was there an issue identified? And then you're giving them a score based on the number of issues that were identified. And then we've got, there's an area here for comments, because usually with the quality audits, rarely you'll see, as with any staff, you'll have somebody come on board and maybe just CDI isn't a good fit. But whenever you're doing a quality audit for them, sometimes that helps you identify a different area that they would be even stronger in, or it helps you identify where you need to provide that education to your staff to help strengthen them and get them where they need to be. So performance reports. There are several reports that can be run to see how well the CDI program is functioning. The number of unspecified codes is one of those. Whenever I would start a program, this is a report I really like to look at. How many unspecified heart failures? How many unspecified pneumonias are we having? Now that's going to be relative to the unit that you're looking at. If you're on the neurotrauma intensive care unit versus the cardiac unit, however your organization is structured, you can run those reports in different ways. You can do it overall as an organization, or you can break that down. If you say we have most of the areas are doing well with a few number of unspecified codes, but you notice that the cardiac floor, the cardiac team, they have a high number of unspecified codes. Then you can reach out to your physician champion and maybe have some peer-to-peer education on that. Because as Kylie discussed earlier, queries are one component, but we want to be educating. We want to be coaching our physicians to learn how to document better. Symptom codes for primary diagnosis. That's another great report to pull in. If you're in the outpatient setting, you're going to see a higher number of symptom codes because they're going to come in with symptoms. And then you have to have time to work up that condition before you're going to have that definitive diagnosis. So it's relative to the location you're at. But if you're in a acute care facility, if you're in an acute care facility, you don't really want to see a lot of symptom codes. We need to get that patient worked up. We need to figure out what the definitive diagnosis is, if at all possible. There will be times where maybe it's going to be the symptom code, but that's a good report to run, and that can help you take a look at the different areas. Number of comorbid conditions, that's going to impact that complexity level that you have. So you can try to run that and see how many comorbid conditions are associated. And you can look at your specific patient population and unit areas to help you define some of these reports that you want to run. If you have a floor that is doing elective surgeries, you may not have as many comorbid conditions, but if you're in intensive care, a lot of those patients, not most of them, but a lot of those patients are going to have some comorbid conditions that you would expect to see. How many complications is the facility seeing? So that's another report that can be run. We mentioned that earlier, that there may be times where you need to send a query to determine if it is truly a complication or not. And then if you've got quality indicators that you're monitoring, that's another important report that you can run as well. And all of this information then helps you focus that education into the appropriate area and the content that you need. Okay, so I think this one's my last slide here on best practices, and this is one of my favorites. Provider engagement, like we mentioned earlier, is really important because we can send 20 or 200 queries a day, but if the documentation is not improved, we're not doing anything with those queries. We have to have engaged physicians. We need to work with our physicians. We need to, whenever the team is being developed, I always encourage organizations to talk to your physicians about their workflow. How are you going to send queries to them? What's going to be the best avenue to send a query to them and communicate with them? Those elements are vital. So whenever you are starting a program, it's pretty normal to see a higher number of queries that are being sent, and you may see a lower number of responses to those queries. But as the program matures, you expect to see those numbers improve over time. Okay, so the table that I have here, this is from a practice brief that we have, or this one's actually pulled in from one of the toolkits that we have. And it was we brought in experts, and we were looking at how can we capture how engaged our physicians are. We can go and talk to a physician, but how do we really know if they're truly engaged? And that's in the work that we see. So what we did was we took a look at the query rate and the associated response rate and started to group this together. So in the query rate, we broke this, well, both of them, we broke them down into apprehension, interest, understanding, and then commitment. These are kind of the 4 levels that we see with our physicians from this group that we worked with, this group of experts. So on the query rate, this apprehension, this is like whenever you very first get started, they're not really sure what's going on, what you're asking of them. I've seen some physicians start documenting just a lot more information, but they're not giving us the right information. We want to make sure that we're clear, and here's the verbiage we need you to use. We don't need you to write 2 or 3 more pages of content. We have to capture the correct verbiage. But as they start to understand what we're asking for, then they start to get into some interest areas. And whenever education's being provided, the financial is vital and important, but I always like to bring in some of the patient positive outcomes from CDI because that speaks volume to physicians. So then you get up to like a 35 to 45% rate on the query rate that you're sending out. And then once they get up to understanding, you're getting up to 25 to 35%. They're continuing to improve. Once you get up to commitment, then they're reaching like a 25% or less. So query rate's kind of a moving target as the program matures. There's also other variables to take into consideration as well whenever you're monitoring your query rate. If you're bringing on new residents on board, new physicians start that have not learned about CDI, they're not sure what's expected, you may see that number move a little bit as they're learning and being educated. The response rate also follows the same type of structure that we did with the query rate. Less than 70% is where we're grouping our apprehension. They're just not sure what they're supposed to do. And again, back to that education piece. I've had, I remember one physician I worked really closely with, was really great to work with, and had a horrible response rate, but he could not find the queries. Like, we just had not gotten the education to him as to how to go in and respond to the query. We thought we had, but we had not. So these numbers give us some great information. And you'll see that move up as well. What we want to get to is a commitment level of engagement with the physicians, which you're looking at a 90 to a 100% response rate to queries. You always have to have a little bit of flexibility in this, because there will be times where they may not be able to give a response to the query. Let's say you have a physician on board, it's a acute care facility, and that query was sent, but then they leave and go on vacation. Well, when you're sending queries, the query should go to a treating physician. It should be a physician who is actually taking care of the patient. And so they left, they go on vacation. Well, maybe they're just gone for a few days, so that query can wait until they come back. But maybe, I mean, if they're, we see this a lot. If you're from a different country and you're working in one country, you may be gone for a month or so to visit family when you're on vacation. So at that point, okay, well, maybe we're not going to get a response to the query because there's not a physician there who has treated the patient. So those are different variables to take into consideration. But this is a great way to help monitor the engagement of your physicians. All right, so that was a quick little overview of best practices. Any questions on that? Either I was really clear, everybody understood everything, everybody's tired after lunch. The link them to the practice brief, yes. And I think Kylie's going to speak to you now about some case studies. Yes. Good question.
As you said, the patient, the physician gone to a vacation. I suppose the physician who were handed over the case, that would be a good reason to actually have the query respond to, because it's very important for him to capture the.
Yes, if he handed off, the patient hadn't been discharged, then I would definitely send the query to the physician that had been handed off to. But this is if they're writing discharge orders, patient's now gone, and you're sending that query retrospective rather than concurrent. And depending on your structure, that's a great point. You can send these queries sometimes while the patient's in the hospital, if it's acute care, or after they've already been discharged. But to that point, I always look back through the record too, because if you've got multiple physicians looking, there's a flag, sorry, multiple physicians that have seen the patient, there may be another physician you could send it to. So that's always good to look at and see if there is another one. You just want someone who has treated the patient and knows the patient. You're welcome. Any others?
Regarding this multiple comorbid conditions patient has, but patient came with pneumonia, respiratory failure with multiple comorbid conditions. So how can we code this as a principal diagnosis?
The principal diagnosis,
Yeah.
choosing well, you're going to follow your coding guidelines for the principal diagnosis. And I think you guys are on AM, so you're going to have to follow the guidelines that are in place for that principal to determine which one is the principal diagnosis. Most usually in general, your principal diagnosis is where you're going to see the most treatment directed towards. You'll see your evidence there. There's an overwhelming amount of evidence and treatment, but sometimes you will see conditions come in where it looks equal. There's two conditions there, like you said, respiratory failure, heart failure. And Kylie can probably address this over in the United States. If it's a situation like that and they look equal, then we could pick either one of them as the principal diagnosis. But I'll see if Kylie has anything to add on that since she's used AM.
Principal diagnosis will be the reason that the patient was admitted. So we say the reason the patient was admitted because you're admitting for respiratory failure with no pneumonia, is the respiratory failure due to pneumonia? So therefore the pneumonia was the reason for admission. So it will depend on the actual case study and then obviously how it's documented. So respiratory failure due to pneumonia, pneumonia is the etiology. It should be the principal diagnosis, the reason for admission. Okay, but if you've got pneumonia and respiratory failure and no link, then, you know, I would be saying, is the respiratory failure due to the pneumonia? And that's the sort of query that we would be asking. And if they say no, then it's up to the clinician to decide, but what was the most relevant, what received the most treatment, most interventions? The thing that if you asked him what was important, the first thing that comes to mind, the focus, what was he focused on? Because while we do talk about equal, very rarely is, do you get everything equal? There's always one thing that they're focused on first as a primary. But the Australian coding standards, which you'll have in your hospital, your staff will have, has like 5 pages on principal diagnosis selection, on how to choose the principal diagnosis. Okay. Anything else? All right. Thank you, Tammy. All right. So this is where I like to play. Okay. So this is the case mix index. The case mix index is a score. I'm going to go over this side. So it's too hot over that side of the room. So the case mix index is a score and a way of measuring the performance of your hospital or the severity of your patients. So what kind of patients do you have, the population? So there's 2 definitions for a case mix. Okay. So for an inpatient facility as a clinical definition, it reflects the sickness of your patient population. So from a clinical perspective, it's how sick are my patients? Okay. Looking at severity of illness, the risk of mortality, our prognosis, what treatment difficulty there was, and what need for intervention. So this is what we're looking for from a clinical perspective. From a reimbursement definition, it's a direct measure of the amount of resource consumption and the cost to provide that care. So you have a reimbursement definition and a clinical definition. So the CMI is a calculation based on the average of these weights that come from your DRG of all the patients treated during a specific time. So you get one big CMI, but you can also get CMIs based on different DRGs in different areas. The higher the CMI usually responds to an increased severity of illness, an increased consumption of resources, increased patient care, increased length of stay, and then correspondingly should result in a higher reimbursement to cover the increased cost and resource usage. So here's a calculator. Okay, it's not automated. It's supposed to be automated. Okay, so I'll have to go through this slightly differently. All right, so, no, sorry, it's automated. This, you're not supposed to see this until the very, very end. So how do we automate? Okay, so I have to use pointer. Okay, I know this, okay, we'll get there. Okay, so what we're doing here is we're starting off here in the number of discharges in December for sepsis and septic shock. So we say 200 patients in December in our hospital, 100 of them were diagnosed with sepsis, 100 were diagnosed with septic shock. Okay, so we have 200 patients in our hospital for December. What happens is we get our number of discharges times our DRG value, which you will find as a nationally weighted activity unit in the ARDRG, gives you the sum total. So 100 times 0.58 gives you 58. Okay, and then this composite DRG is the adding up of these composites. So 100 septic shock. This is probably easier. 100 septic shock, but septic shock has a higher weighted unit. So 3.65 versus 0.58. We've got 365. Now we do a CDI review of our sepsis and our septic shocks because the Australian coding standard says sepsis, even with multiple organ failure, mortality, all of these things, cannot go to septic shock if it wasn't written. It can't even go to severe sepsis if the clinician doesn't write severe sepsis. It just has to go to sepsis. Okay, so it's pinned on the documentation. So we do our review and we go, hang on a second, our patients with these organ failure, they actually had septic shock. They meet the criteria. Okay, so they've met either sepsis through whichever criteria you're using. So now we're changing this. This drops to 60 for December and goes up to 140 for septic shock. So what we do is we have new composite DRGs. So sepsis has gone down, a decrease of 23 points. Septic shock has gone up 146 points. And again, we do this composite and add it up. So what we do then is to get our CMI is we get our total composite and we divide it by the number of patients that we use to get that. So 2.11, our change up 0.61, 273. Okay, now this is where this is supposed to bounce in and get you all very excited, but it's already there. So we're working on the CHI's nationally efficient price of 10,000 Riyals. Okay, so this is where we got this number from. So 10,000 Riyals times the 2.11 from here. Okay, times 200 cases is 4 million Riyals per month for our 200 patients. Okay, we changed that with our changes and with our review. So we're now at 5.4 million Riyals per month. You do this for your patients and you average 40 per month for 12 months, you've got 14.5 million Riyals that you were going to miss. So that's a big number. That's 2 DRGs, and there's more than 800 DRGs in the ARDRG system. And I've given you 2. Okay, so you can see that there's a big opportunity for lost revenue or gained revenue based on physician documentation on just one topic, just the sepsis. Okay, so this is where the value is. So if you're having trouble getting buy-in, especially from the finance, to get the money for your program, take them this slide. Okay, all right. So the summary of the CMI, it has a clinical definition, it has a reimbursement definition. We have the proper calculation is essential. The hospital can't operate if it doesn't get paid for what it does. We need a rising CMI implies the hospital is treating our patients, they're more complex, so we should be paid accordingly. If our patients are sick, we should be paid so. A decline could indicate that there's a shift in maybe the volume of patients, or we have a lack of thorough documentation, or we have coding problems, which is then when we go and assess the coding. Are the physicians documenting? Yes. Are the coders needing education on how they actually should be coding this? Because there'll be gaps all along the way. Okay, slight shifts. So 40 patients a month, over 12 months, 14 million Riyals. Little shifts make a big difference. And then you can analyze this for revenue, for budgeting, for planning for your future, knowing your patient complexity, targeting where you're going to develop health promotion, where you can develop education for your patients, what resources you need, what clinics you need to implement, what physicians you need to employ. All of these things can come through from this documentation and your CMI. Okay, so now we do some case studies. Okay, so this is some more examples. And again, it's that same kind of thing. So these are cases where we have very average documentation, very common documentation. And what we've done is got more specific. And then you can see the difference. So for example, this is a 13-year-old male patient, admitted for adenoidectomy, has enlarged adenoids, heavy snorer, general anesthesia with an ASA score from 1. So when this is coded out, we're only going to be doing the enlarged adenoids because that's all we've got documented as a diagnosis. We're going to do the snoring, okay, because it's all we have. We don't have anything more to give to it. We have condition onset flag in the Australian coding system, which says this was present on admission. We have a diagnostic complexity level, and these scores, diagnostic complexity levels, add up to give us our episode score, And our episode score is what drives our DRG. Okay, so this is where we get our changes in our DRG based on the episode complexity score. All right, and then we have our procedures. So our procedures have made this a surgical patient. Our codes have made this ear, nose, mouth, and throat. We get a D11Z DRG. Now, the problem with the D11Z DRG, no matter what codes I throw at this patient, I'm never going to change that DRG because Z says no split. Z is the only DRG. All right, so we're going to get, in a Saudi context, for a medical city, 10,000, a 0.38, 38,000. Average length of stay, 1 day. Okay, which kind of makes sense for an adenoidectomy, overnight stay. 13 makes sense. All right, let's improve the documentation. Okay, this patient actually has obstructive sleep apnea and they're having the adenoidectomy. Okay, it meets the criteria from the clinical criteria. They still have their enlarged adenoids and they're still a heavy snorer, but we actually have a diagnosis. Okay, enlarged adenoids is a sign. Now we have a diagnostic statement. So now we have obstructive sleep apnea as the principal diagnosis. We still have the enlarged adenoids. Okay, and we have our procedures. I dropped the heavy snoring because it just doesn't do anything. Condition at onset flag, still 2 because it was present on admission. Okay, but look, no diagnostic complexity score. It's disappeared. But what has happened is we've changed from ear, nose, mouth, and throat to respiratory. We're now in the respiratory diagnostics, the DRG. Still surgical. We now have EO2C, other respiratory systems with minor complexity. We've got a cost rate 0.81 or 0.202 in the Saudi context, 20,000 riyals. Okay, still with a 1 day length of stay, by the way, but 20,000 riyals. Okay, because of the complexity involved in the treatment. Okay, so all we did was got a diagnostic statement from the indicators. Okay, so this is the kind of thing that happens when we get this diagnostic. Not all of the time do you get a financial gain. Okay, so I'll do a couple of financial and then I'll show you some others. Okay, because not always do you make money. Sometimes you actually lose money, but you get better scores. Okay, so here we have chronic intractable pain, osteoarthritis lumbar spine, and they're doing an epidural injection of a local anesthetic. Okay, so all we have is osteoarthritis, unspecified spondylosis, okay, lumbar, and chronic pain. So our osteoarthritis gives a diagnostic complexity score of 2. We're doing an epidural injection. That doesn't count as surgical, it stays as medical because it's an injection, not an infusion. Okay, so we have our procedure. We are in musculoskeletal, makes sense. It's medical. We have an I68B, which is a non-surgical spinal disorder, minor complexity. Okay, episode complexity is 2, reflective of this. Okay, and 1.3, 13,000. Average length of stay is 1. Australia average length of stay is 1.6. Okay, so we're just working with what we have. When we're looking at this, we talk about when do we have a split. So for this DRG, which is I68, we have A and B only. So B is the lowest one, and A, if your diagnostic complexity score is 2.5 or above, you would swap to the higher level, so the higher payment, because minor complexity would become major complexity. Okay, so here's 13,000. Okay, now we've gone a little bit further, and on the imaging report that said there was a slip disc. So we got the doctor to document the slip disc. This hasn't changed, but we do have further specificity of the injury and the pain. So we have another diagnostic complexity score of 2. We've made a 3.5 because it's an algorithm and a calculation. It's not straightforward math. Okay, and now we've gone through to a major complexity. We've gone to 4.6 payment, 46,000, with a length of stay of 6.3. So that's the average length for, and it's still your standard epidural injection. Okay, because we have specificity. Okay, and it's linked because they're all lumbar. They're all where we're working. So this is where we talk about the complexities. These comorbidities add complexity. Okay, we have another one. Okay, so here we have a 73-year-old male, has a hip fracture from a fall requiring open reduction internal fixation under a general. We've got pre-op hemoglobin, 12.5. Post-op, you can see it's decreasing. 11.4, 10.2, 10.3. No transfusion was given. There were no documented symptoms, but they did treat him with iron. They said treatment's iron sulfate. The diagnosis was pre and post-op anemia with anemia workup as an outpatient. So the reason for admission is the fracture, neck of femur. Okay, and then the external causes of where and how that mechanism occurred. So we know it was a fall. We know, we don't know where it occurred. We don't know what the patient was doing, and we don't know what kind of anemia. We're just going with anemia unspecified. So as Timmy said, we want to get rid of these unspecifieds. And then our surgery. So musculoskeletal makes sense. Right diagnostic category. Surgical, yes, makes sense. It's other hip and femur, minor complexity. Okay, very straightforward. Episode complexity score of 1 coming from the anemia unspecified. 15,000, average length of stay 6 days. See, so our split is greater than 3.5 for the highest payment, greater than 2 for the middle payment, and anything else below that gives you the lowest payment, which is what we have. This one, sadly, doesn't give you any more money. This one is about the specificity. So now we have identified that it's an intertrochanteric fracture. So we know what kind of fracture we have. Okay, we know that the patient fell down the staircase at home while he was cleaning the step. So we know that it was a fall from one level to another, and we know what he was doing at the time. So it was a slip. It's 73. Is he unsteady on his feet, or did he just slip on a wet step? It changes your care and your focus and your discharge. We also said that we have iron deficiency anemia chronic because we know that his hemoglobin was 12.5. But we're just saying it's iron deficiency. We got this from outpatients and documented. And then this meets the criteria for acute blood loss. And we document that we've got acute blood loss post the surgery. Okay, so we get all of these. And now we've said the treatment with iron sulfate was IV iron sulfate and discharged home with oral iron as well. Okay, so now we have specificity. So these are the things you're looking for, is specificity. What kind of fracture, where and how, what was the mechanism? So the external cause of injury was a fall. There was indoors and he was doing domestic duties. He was cleaning his step. Okay, we have iron deficiency anemia, the chronic anemia, and we have the acute post-hemorrhagic, the ABLA. And the condition onset flag for the acute post is a hospital-acquired condition. It is not present on admission. This was, the chronic was present, the acute was not. Okay, so it's important that we identify when these things occur. Again, still musculoskeletal. You see, we haven't changed anything for the finance, but we do have a diagnostic complexity of 1. It just is not enough to increase. Okay, so again, like I said, not always does it add dollar value, but it does identify complexity. Okay, and it identifies present on admission or hospital acquired. Next one, acute, this is a sepsis one, so I thought you might like sepsis. Admitted with a community acquired pneumonia. Despite 5 days of IV antibiotics, patient became feverish, temperature, respiratory rate and heart rate increased, was transferred to the ICU with a diagnosis of sepsis, with multiple organ failure and passed on day 3 despite resuscitation attempts. Okay, so we've got sepsis with multi-organ failure. Can go nowhere with that. The reason for admission is the pneumonia. It doesn't say that it's bacterial, it doesn't say it's viral, so we have to go with unspecified. We would do a sepsis unspecified because that's all we've got, sepsis unspecified. And the only thing you can capture for a multiple organ failure with no specificity of what organs is general signs and symptoms, because there isn't multiple organ failure without documentation of what organs are failing, because the assumption is in the healthcare system, you should know. So they don't actually give you an option for this one. So we're in respiratory, makes sense. We've got pneumonia. Our episode complexity is 1 from our pneumonia. We're in a B split, a minor complexity, because sepsis is considered a minor complication. And we have our 4,500 and an average length of stay of 3. We already know that this patient's been there more than 8 days, but you're only going to be paid for 3 of them. The average length is 3 for a sepsis patient unspecified. We change things up with the documentation. Okay, we still don't know what kind of pneumonia it is. We still don't know what kind of sepsis. We've got no bacteria, any of those things. But what we have got documented is that a diagnosis of severe sepsis was why the patient was admitted to ICU. And now we have septic shock with multiple organ failure, respiratory, renal, and cardiovascular, and passed, despite the resuscitation. Okay, so we know this patient is very, very ill. Okay, so we can capture all this. We do get another diagnostic complexity score. So we get to 2. We do increase. Do we increase our money? No, because we didn't get to 2.5. But what we do get is a risk of mortality score, which is probably a good thing seeing that our patient died, but we do get a score for risk of mortality, okay, based on the congestive heart failure. Okay, so like I said, sometimes it's not the money that changes, it's the other severity indicators, the risks of mortality, the complexity, the comparisons, and raising attention for quality purposes. So do you review this patient? What would you have done differently? How would you document differently? Okay, so that's it for the case studies. Is there any other questions around those? Do you like case studies? Yeah. Okay. Everybody likes case studies. Okay, so.
Hi,
Yes.
Kylie. If
Hi.
I may ask about the national efficient price, where
Okay.
does it come from?
Oh,
And
okay, so this national efficient price comes from CHI, which is just the one they set, 10,000 CHI for a tertiary institution. This is where this is working on a medical city. So they have 3 levels, less than 50 beds, greater than 50 beds, and a medical city and tertiary. So that's the CHI score. Okay, so that comes from them. These ones here come from Australia using the Australian DRG. And the nationally efficient price for Australia at the moment is 5,000, roughly 5,000 Australian dollars. So probably 14,000 Saudi riyals. Okay,
Then
so
would it be accurate to use the DRG for us to calculate our cost weight? And
the cost weight should be where you're going to have some struggle is going to be with the length of stay. Because the way the Australian system is set up, the length of stay is based on an acute length of stay. So this is an acute DRG based on when the patient is acute. When the patient is subacute, it actually changes a financial episode. It's called a statistical discharge, and it goes into a different funding model. Okay, so this is where things get a little bit tricky for you. Okay, with the implementation of a Saudi DRG, it will obviously be reflected of Saudi's average length of stay. But when you're looking at this from a coding and from a HIM perspective and looking at this as a perspective, it just gives you somewhere to work. What you will see on your code finder and on your software systems, what we call low boundary and high boundary days. So for this particular DRG, the patient should be discharged before 1 day and could stay as long as 9 days for that payment. Okay. What happens in the Australian funding model is we would actually statistically discharge this patient to the convalescence or subacute care when they are just getting nursing care, when they're no longer considered acute. And that becomes a per day rate payment because it is nursing and allied health and less clinical intervention. Okay, they may stay in the same bed, by the way, but it just identifies the resource usage. So this is slightly different. And I do know that here they have looked at, and it's called ANSNAP. So it's the Australian National Ambulatory Subacute and Ambulatory Pricing Program. I can't remember now, it's gone. And then tier 2, there's a whole range of different funding models, still using the same code, still using the DRG, but how you're paid varies based on the care type or the acuity of your patient. So a rehab patient would be paid on a per day rate because we know that's long and slow. Okay, and we can't say that this patient will go home in 9 days, this one will go home in 30 days and 50 days. You get paid a bed rate. So still has a DRG, but a bed rate payment. Okay, so you can use the length of stay with an awareness that it is talking about the acute part of the episode. So if you're going to have an acute hip replacement, and then you're going to do your rehab in your hospital for 2 weeks, 3 weeks, obviously your length of stay is going to be much longer. And this is something that you can be aware of and talk with your physicians. One of the hospitals here actually asks the physicians to document when they are no longer acute. They can't change the care type at the moment, but the doctors are documenting when they are no longer treating the patient acutely, when they are now in rehabilitation, palliative care, subacute care, convalescence. So they're actually documenting it so that they can, for their own records, work out, are they meeting that criteria? Okay, big, like I said, big ask for the doctors. Yeah. Anything else? No? Good. So,
Okay, great. Thank you, Kylie. Let's take a 10-minute coffee break and convene at 10 to 4, 10 to 3. After that, we have a section on technology and how technology can help you in RCM, health information, coding, CDI, and so on. And after that, we wrap up the session. So 10-minute coffee break, please, and we'll be back here. Thank you. Assalamu alaikum. Welcome back. إن شاء الله الكل أخذ بريك، ريحتوا قهوة مي. مثل ما قلنا بنبدأ هلا سيشن مع شركائنا بالتكنولوجي. بحب رحب بالأستاذ أنس بطيخي اللي هو المدير العام لشركة سانتكتشر، شركائنا بحلول التكنولوجيا بالRCM. أنس.
شكرا إلي. مساكم سعيد جميعا. وسمعتوها صح، أنس بطيخي الاسم صحيح، ومنرحب فيكم جميعا. شوي في بس ضوء قوي. احنا شركة سانتكتشر مختصين بتطوير أنظمة الترميز وأنظمة الفوترة RCM Revenue Cycle Management Systems. عندنا عدة أنظمة. هنركز اليوم على نظام الترميز واللي هو كود ماين. بس قبل ما نبدأ هنعطيكم بس فكرة عامة عن الشركة وعن الأشياء اللي بنقدمها إجمالا اللي مختصة بالقطاع الصحي في المملكة العربية السعودية. شوي المايك حساس. طيب نحن بس ناخذ فكرة عن المشاكل اللي أو التحديات خلينا نسميها اليوم بالنسبة لموضوع الفوترة في البلدان المحلية أو المجاورة، مثلا مثل الإمارات. الإمارات بدأت بموضوع تعميم التأمين الصحي والفوترة بال2008، هذا من 14 سنة، وما زال في تحديات بموضوع الفوترة الصحيحة وبالتحديد تخصيص الأنظمة تفعيل موضوع الاوتوميشن او الفوتره الاليه الى اخره، وما زالت التحديات جاريه، ولكن نعتبرها احنا نوع من الماركت المتشور نوعا ما، اللي هو مر بتجربه على مدى 12 سنه 14 سنه، وصار في تطوير للانظمه وللتخصصات بالنسبه للترميز الطبي والسي دي اي وكل المواضيع اللي حكينا فيها اليوم، واللي هي اليوم تم تطبيقها على النظام الفوتر الامريكي بالنسبه للاي سي 10 سي ام والسي بي تي 4. طبعا our partners او شركائنا في AHIMA, I'm sure they discussed the coding and the challenges in general. Today we're going to discuss او اليوم حنركز اكثر على التحديات المحليه في المنطقه. عم نستشهد بالامارات باعتبار في تجربه تم خوضها، وهلا بنحكي كمان على المملكه العربيه السعوديه. التحديات هي نفسها سواء في المنطقه او بشكل على مستوى عالمي. اليوم في عندنا تكلفه عاليه بالنسبه لعمليات الفوتره اجمالا، عندنا نسبه رفض عاليه للمطالبات. هي مشكله حقيقيه عم يعاني فيها جميع المستشفيات حقيقه بالقطاع الخاص او القطاع العام. في عندنا مشكله اليوم الهدر او التسرب المالي بنسميها الريفينيو ليكج، ومتابعه الامور او المطالبات وقيمتها بشكل دقيق، ورفع التقارير وتحصيل الى اخره. طبعا نحن يعني عندنا اطلاع اكيد على موضوع نفيس والتحديات اللي انوجدت مع منصه نفيس. طبعا منصه نفيس بيرادفها منصات اخرى سواء في الامارات او حتى بالولايات المتحده، لكن منصه نفيس تحديدا عممت موضوع الترميز الطبي بقالب محلي. مين بيعرف هون ال SBS؟ Do we know what SBS stands for؟ طيب ممتاز. سانتكتشر نوبيليتي واكيوميت كشركات كانوا خلينا نقول مختصه بكل بمجالها، طورت بالشراكه مع مجلس الضمان الصحي نظام الفوتره السعودي. طبعا لما طورناه كان في بدايه من النظام الترميز الاسترالي، وبنينا عليه حتى يكون اليوم يتناسب مع متطلبات الفوتره والترميز في المملكه. اجمالا خلينا نقول المقاييس والتطبيقات والتشريعات تجي اولا، والتنفيذ واكتساب الخبره تجي ثاني. فنحن اليوم عم نحكي بآلية كيف نحن اليوم حنطبق الترميز وتفعيل الفوتره بشكل فعال وجيد، وحنعتمد فيه اكيد على خبرات زي الاتش اي ام والكودينج والمرمزين والسي دي اي وكل المفاهيم اللي حكينا فيها اليوم، بالاضافه ل التكنولوجي اللي هي اليوم حتساعدنا بتطبيق اسهل ان شاء الله وافضل. بستشهد من ماكنزي كومباني بالنسبه لدوره اداره الايرادات. طبعا في عندنا هذا ما فيه ليزر صح؟ في عندنا اللي هو معروف اجمالا النقاط اللي هي فيها اداره المطالبات، الترميز وتدقيق الملفات الطبيه، وطبعا موضوع البيشنت اكسس البري اوثرايزيشن وتسجيل المرضى. هذول معروفين عنا، لكن في عنا كمان اشياء هي بالمخفي اكثر، اللي هي موضوع اداره العقود، خلينا نقول الكلينيشن بيهيفير لحتى يدعم عمليه الفوتره وتغيير العاده بالنسبه لآلية التوثيق الى اخره. واكيد كان في نقاش على موضوع السي دي اي ودور الفيزيشن او الطبيب فيه، واكيد طبعا تفعيل الملفات الطبيه الالكترونيه اللي هي حتدعم مواضيع الاتمته وتسريع عمليات الفوتره. يمكن تشتغل بس من هناك. اوكي. طيب فنحن اليوم عم نحاول نوزع المهام او المسؤوليات ما بين المرمز والفيزيشن والبيلر، وخلينا نقول الريسبشن ديسك امبلويي والبري ابروفل او الموافقات المسبقه الى اخره. بالنسبه للسوق او كماركت ان ذا يو اس اللي هو نعتبره احنا اليوم ماتشور موضوع الفوتره الى اخره، حنشوف انه في عندنا احنا نسبه كثير عاليه موضوع الرفض بسبب الترميز الطبي الخاطئ. هي ما زالت مشكله بيعانيها حتى اكبر الاسواق اليوم او اكبر الاسواق اللي طبقت او الانظمه الصحيه اللي طبقت عمليات الترميز والفوتره. لحد الان نحن لسه ما واجهناها بشكل كامل في المملكه، لانه موضوع الترميز الطبي ما زال نوعا ما حديث العهد، وما زال العمل عليه في تطور. نحن عم نلاقي هلا تحديات فعليا بموضوع الفوتره يعني اكثر بالجانب التقني او الجانب الطبي بالنسبه للميديكال نيسيسيتي او بالنسبه لتطبيق البروتوكولات الفوتره الصحيحه. نتبع يعني آلية الفوترة الصحيحة، لكن موضوع الترميز الطبي حيظهر مع الوقت كسبب أحد الأسباب الرئيسية لرفض المطالبات الطبية. طبعا نحن كسانتكشن بنركز أكثر على تفادي هذه الأخطاء وأكيد نسرع الإجراءات بموضوع إنه اليوم نحن بدنا نوصل من الموعد لتحصيل مبالغ الفاتورة بأسرع وقت ممكن، نقدم أفضل خدمة وناخذ مقابلها جميع المستحقات المنشأة أو الكادر الطبي كدخل. طبعا الفرق ما بين يعني عدم وجود تقنية عالية ووجود تقنية عالية حيكون أكيد بموضوع الافشنسي او الاداره الافضل او سرعه الاداء ودقه الاداء. بالنسبه لنا عندنا خبره طويله، بدانا في الامارات، وسعنا ما بين الهند ومصر والسعوديه من حوالي 3 سنوات، وعندنا تعاون اكيد مع وزاره الصحه بالنسبه لبعض الانظمه، وبنتامل يكون في تعاون برضه ب مجالات متعدده. عندنا احنا انظمه مثل كود ماين اللي حنحكي بشكل موسع عنه اليوم، النظام المختص بموضوع الترميز الطبي يلي هو تم تطويره خصوصا بقالب محلي للمملكه العربيه السعوديه، بيطبق الاس بي اس، وبرضه فيه كمان الاستراليان كودينج ستاندردز. ثينك هو عباره عن محرك قواعد او رولز انجن، رول اديتس، ميديكال نيسيسيتي او فيها insurance rules، فيها الكودينج rules ك validation or automation للreview of claims and medical documentation. روبن هو automation للRCM process، وكيوب هو عبارة عن cloud EMR. فبتلاقوا اليوم احنا عم نغطي كل احتياجات الفوترة والترميز وإدارة الملفات الطبية بأنظمة مختلفة، ممكن يكون ندمجهم مع بعض أو نستخدمهم مع الأنظمة الحالية الموجودة في بيئة العمل اللي في مستشفياتنا أو في مجال العمل. حنمشي بس بشكل سريع. طبعا حب أذكر هون إنه موضوع think ككونتنت فيه أكثر من 4 مليون بنسميها قاعدة تحقق، اللي هي اليوم بتشيك على ICD مع آتشي مع بروتوكولات التأمين، مع تشريعات المجلس، مجلس الضمان الصحي إلى آخره. فهو بنلاقي احنا فينا نعمل إدارة كاملة للمطالبات بشكل آلي وبشكل منظم من خلال الرولز انجن. وطبعا بناخذ منه التفاصيل وين الاخطاء وين ممكن يكون في خطر بالنسبه للمرفوضات الى اخره. بالنسبه لكود ماين هو اليوم نجم الحفل اليوم صراحه، هو كود ماين. انا بس كنت عم بعطيكم فكره عن اشياء ثانيه احنا يعني بنوفرها، بس اليوم كود ماين حنحكي عنه شوي اكثر بتفصيل. حنعرض فيديو سريع، وفي جائزة لكم لكل شخص موجود معنا اليوم بنهاية البرزنتيشن إن شاء الله. ونتابع سوا بشكل سريع بس الكود ماين وطريقة عمله، وبنرجع ندخل بكمان مثل ورك شوب بسيط حتى نورجي كيف نحن بنعمل فوترة او ترميز وتجميع بالنسبة للدي ار جي على نفس النظام. طبعا كود ماين بيوفر نظام الاسترالي، نظام الفوتر السعودي كمان بالاضافه للنظام الامريكي كمحتوى. يوفر الاندكس للاي سي تي 10 اي ام كاندكس وكليدنج تيرمز. اللي بيميز نظام كود ماين انه يمكن الدخول له من اي مكان، هو عباره عن ويب بيست ساس سولوشن، ممكن ندخل عليه احنا مو شرط يكون من مكان العمل، ممكن ندخل عليه من اي مكان داخل العمل او خارج. طبعا بيتبع التشابترز بالنسبه للاي سي تي بشكل كامل، هذا عم بالاضافه لتفاصيل عن كل نظام ترميز، عفوا كل كود تشخيص ومقاييس الترميز نفسها، ومبني فيه كمان موضوع الكودينج رولز سواء بالنسبه للنظام الاسترالي او لنظام الفوتره السعودي. حاليا جاري العمل على نظام فوتره سعودي نسخه معدله نسخه 2، فان شاء الله مجرد ما يتم طرحها من مجلس الضمان حيكون موجود متوفر بشكل مباشر. طبعا بيعطينا كمان الفاليديتي تبع الاي سي دي كود بالنسبه لعلاقتها مع الليدنج تيرمز. بيتضمنوا كمان الانكلود واكسكلود بالكودينج رولز والستاندردز طبعا بشكل اساسي. إضافة للآي سي دي في عندنا ضمن النظام نظام الفوترة السعودي بشكل كامل، ممكن يتم يعني استخراج كل الأكواد منه، بالإضافة للآتشي اللي كمان هو موجود تحت إعدادات خلينا نقول النظام الأسترالي، إذا فينا نقلب بين الأسترالي وبين النظام الفوترة السعودي، إذا كان في داعي للمقارنة حابين نشوف اساس الكود جاي من وين، لانه مثل ما بنعرف احنا اليوم نظام الفوتر السعودي هو مبني اساسا على نظام او مقاييس الترميز الاسترالي. بنشوف هون كمان في عندنا يعني مضاف عليها كمان الاي دي جي ام، عفوا شو هي اسمها؟ جي ام تي ام والاس اف دي اي دراجز والكونسيومبلز. ف يعني كل الستاندرز اللي مطروحه بالنسبه لنفيس بمكان واحد. حاليا نحن عم نضطر نروح للاس اف دي اي لنجيب الدراج سيبريتلي، بنروح لل جي ام تي ان تنسى. وبرضه كمان الدنتال كودز موجودة ضمن المحتوى. وبالمناسبة الدنتال كودز حيتم إضافتها للإس بي إس كتشابتر كامل، ويتم إلغاء الاي دي اي اللي هي الأستراليان دنتال أسوسيشن كودز. بس يصير هذا التعميم حندمج احنا برضه الكودز مع الاس بي اس كتشابتر كامل. طيب بتوقع الفكرة يمكن واضحة بالنسبة للنظام. رح أطلب من زميلي الدكتور شريف يقدم لنا الآن مثل وركشوب عملي إنه كيف نحن ممكن نرمز الحالات وننشئ منها أو نستخرج أو نجمعها بنظام الدي ار جي، ونقارن كيف النظام رح يساعدنا على ترميز أفضل وسهولة الاستخدام بالنسبة لعمليات الفوترة أو عمليات تجميع الدي ار جي. تفضل.
Thank you, Anas. Thank you all for being here. As Anas said, that CodeMine has all the essentials and all the Saudi code sets present in one place regarding ICD-10, SPS, GMDN, and GTIN, and the ADA, which is the Australian Dental Association. There is no need to go anywhere to search for any code, like go to the GMDN search website or the GTIN. It's all present in one place. It's called CodeMine. Now we will go for the action part. We will use the Kylie scenario cases that presented earlier to put it into action into CodeMine application. Okay, these are the first case scenario, which is the patient 50 years old, he's male, having chronic intractable pain, osteoarthritis, lumbar spine, and undergoes epidural injection of local anesthetic. Now we will take the code, the primary diagnosis, and the additional diagnosis and the procedures, and put it into CodeMine to see what is the DRG code will come out, and what is the financial impact of the code that we choose. We'll take the first code, put it here. And this came as a primary diagnosis, unspecified spondylosis lumbar region. And we will take the secondary diagnosis, which is the chronic pain. And then we will take the procedure, which is epidural injection of local anesthetic. Okay. Now we both, of course, we have to fill all these fields, which is necessary to calculate the proper DRG code regarding the gender, date of birth, same day surgery, or he has to stay in the hospital, admission date and separation date, and the length of stay. But we put it before to make the things easier. Now we will click on the submit button. Now here is the DRG, what it should look like. Here is the DRG code I68B, and the DRG description, the non-surgical spinal disease, minor complexity, and the average length of stay is 1. And the most important thing, that the price is showing here according to the previously published MOH prices, according to the Article 11. You can print it out through PDF. Here, you can print it or save, or whatever you like, you want to do. You can do it through CodeMine. Okay. Now we will go to scenario number 2. We will add the additional diagnosis, which is other specified vertebral disc replacement. Suppose that the coders did not or miss a diagnosis of the disc prolapse.
he read it again, and with the proper clinical documentation, he has to pick up the diagnosis, which has a greatly impaction on the financial outcome or the revenue cycle. We will add it here. Okay, we will see what is the DRG come up with. Here, as you can see, that the DRG code, the complexity level is increased from minor complexity to major complexity, and the price also increased up to 46,000 riyals, from 13,000 riyals up to 46,000 riyals. This is a real example of how the importance of the clinical documentations are and how to pick up the proper diagnosis of the patient and what is the comorbidities the patient has in order to come up with the proper DRG code, and in order to make also the financial impactions on the cases itself. Let's go to the case number 2. Case number 2, which is the patient aged 13 years old, and I prefer to put it here. Can be okay. Age of the patient is 13 years old. He's a male admitted for adenidectomy, enlarged adenoid, and heavy snoring. We will take the first code. Okay, hypertrophy of adenoid. Mouth breathing. Okay. And we will take the procedure, which is the adenidectomy without tonsillectomy. Okay. We'll click on submission. Perfect. Much better. Okay. You can hear me well now? Okay. The code is D11Z. And the medical and here is the descriptions of the DRG, which is tonsillectomy and adenidectomy, and the price is 3,800 riyals. What if, as Kylie said, that the admission diagnosis will be obstructive sleep apnea? We will see how this one will impact financially and the complexity of the DRG. I will just put it here, and we will see a check right now. If we make submission, it doesn't change. This is because it has to be here as a primary diagnosis. This is the one of the, convenience features of the code mine, that you have that you can swap between the primary diagnosis or the secondary diagnosis. Now we can put it here as a primary diagnosis of obstructive sleep apnea. Additional diagnosis should be hypertrophy of adenoids. Additional diagnosis mouth breathing, which will not affect anything. And the procedure is still the same. Now we will click on submit. Now you can see the DRG code is changed. The complexity also is changed, or the descriptions of the DRG instead of the ENT becomes respiratory problem, which is the obstructive sleep apnea, and also the amount of the money that you can get out of that patient is increased from 3,000 riyals up to 20,000 riyals. This is the importance of the code mine, how it will affect your financial outcome and your revenue cycle management. So this is a brief about the code mine, how it works. The code mine, as Mr. Anas said, it has all the code set of the Saudi market. Actually, it is custom based on your reviews. Actually, it's not our product, it's your product. You built this one from your reviews, from the feedbacks that we can get from our partners and MOH providers. You build this one. We take your ideas and put it in place and put it into action, and now it works, as you see. We have SPS, alphabetical, tabular. You go through the video. You know all of this one, but I will just quickly go through it. We have also e-books instead of the books. We have here educational information like SPS coding standard. So we have all the coders should need to code a case properly. Here, I think you don't need a nobility courses anymore. You can go through CodeMine and search for the learning.
Okay, maybe we should stop him now.
Let me continue.
He's joking with you, by the way.
I'm joking. That's a joke. Okay. And we have some of the coding rules and the dental. We have all the dentals in the search. We can search like that, crown, dental, and the dental code will show right up. We have the dental code 658 with its descriptions. You can copy the code or copy the descriptions. You can increase the font or decrease the font. One of the weird reviews that we came out of the providers is that the user prefer the dark background around 40%, and the other 60% prefer the brightest background. So we made it both. He can go dark, he can go light. So we add many convenience features for the coders to make his life easy. It's like his body, not an applications or the product. He can open it up from anywhere. It's not disk-based. He can open up from the laptop or from cell phone. So it's very easy to access it. Consumable, like we are using here the GMDN, which is the Global Medical Device Nomenclature. We can search like Lancet and all the Lancet with the GMDN term code and with its description will show. And the drugs here, as we can search by trade name or commercial name, Panadol for an example. Okay, here is the Panadol, the GTIN number, and we have the dosage form and everything. We have also here the SFDA number. We can drug name, SFDA code. We can take it from here. That easy. We have also the DRG grouper, which is very important, I know, for the MOH department.
Okay, Dr. Sharif, thank you so much. I think everyone is tired after a long day and they don't want to see any more code.
Yes.
Yes, go ahead.
Yeah, you more than?
More than one word. Yes, can you put two words, like, for example? Put accident and car.
I think.
Space, car.
Okay, here is all the accidents code sets. You can filter it by the ICD-10 only. You can, here is all the code sets. Here is a chapter, car occupant injured in transport accident. It's very easy to search.
Yes, you can search on multiple. Absolutely,
yes.
To make it more specific, sure.
Yeah, this is the advantage of CodeMine. You make things complicated now.
Of course, of course. What
Yes.
would you like an example if you have?
Company?
Camel. Car accident with a camel. That's an interesting one.
Yeah.
Is there a diagnosis code for that? There is. Wow.
Let's search by camel only, can be. Let me
Let's
see.
pick the first one. Go to read more.
Camel. We just put camel. No.
I don't think there's a camel in the ICD. Animal maybe.
Yeah, maybe. Maybe
There is?
animal.
Camel. not animal, but cattle. Put not cage, put animal, accident. I'll tell you what, I did promise you a nice gift. So each one of you now get a brochure. You have inside a 30-day free trial for the solution. You can just register, use it. You can put camel, horses, rabbits, whatever you like, and see if it comes up. You can play with it. You can do grouping. You can look up any codes, and we're always happy to help. You can use the help section if you need any assistance. If you need any guidance, also we can schedule a Zoom or a Teams call with you to take you through it. But you're more than welcome to use it. It's free for 30 days. And if you like it, you have to pay for it. Thank you so much. And I hope you enjoyed the day. I'll pass it back to my friend and colleague, Mr. Dawa.
Thank you, Anas and Dr. Thank you. May I ask my friends, AHIMA, Kylie, to join me on stage? Kylie, you can join us as well. So to wrap it up, we'd like to, first of all, thank you for being with us today. We'd like to answer any questions that you might have about today's presentation, about going forward. What challenges do you see at your institutions in implementing clinical documentation and taking this forward? What do you think you will be taking away with you today from our presentation back to your offices and organizations? Any suggestions to hear from you? So please let us know. And Matt, if you want to, please.
Only to say that I think we've learned after our morning and part of the afternoon together that CDI is a complicated process. Quick show of hands, how many of you are feeling a little nervous about embarking on a CDI journey or expanding your organization's CDI approach? And how many of you would raise your hands, but you're nervous to raise your hands and admit that this seems like this might be somewhat difficult? Yeah. We want to make sure that you know that you have support in this. It's a long journey. It's a journey that's going to lead to really phenomenal results as you make progress along it and as you get to the end of it. But we're here to help you as part of that process. We want to help you. So you're not alone. You have partners here in the region. We're here to help as well. So please let us know what we can do to help you. While we're here with you today, we would love to hear what are the things you think might be challenges or barriers for you that we've not discussed and we've not addressed. And I guarantee you, if you have a challenge or a barrier that you're thinking about, somebody a couple of tables over is having the exact same one, and they're just a little nervous to raise their hand and share it. So I'll ask you to be brave and to share with us what you think might be some of the obstacles, and then we can provide a little bit of advice or some resources to help you approach that. So we'd love to kick it off to you. What issues, worries, concerns, questions do you still have? Yeah.
Experience with the other countries and other healthcare sectors. What was the main challenges for them, and how do you overcome these challenges, and how long it took them to reach to mature level in the CDI? So we'll learn from their experience as a lesson learned for us to start from where they ended.
Yeah, absolutely. So I think some of the biggest challenges that we've seen out there, number one is physician engagement. Whenever you're starting CDI, our physicians are really busy, and it seems like just one more administrative task that you're adding on top of them. So it's important for the physicians to understand why. Before they start getting any queries, there should be some education. There should be some support. They need to be familiar with the CDI team. That way you've got that buy-in from the very beginning. And that makes a big difference just getting started. Training, making sure that your staff has adequate training, especially if you're going to implement software. We just saw some demonstration of some great software, which is really vital to have in place, because you want your CDI team to know what kind of impact the documentation changes are going to make. and they need to understand how to get in there, how to use that. So having that training as well as just basic CDI training is essential. So that awareness, that education is key. And take some time to really understand which, like your software, the technology, what is going to be best for your organization. Like I said, we just saw a great demonstration, but understanding, what you're going to need, because what we saw is like putting the codes in, that's pretty much essential. You really need that. But there's other technology out there available. Do some research and see if there's, something else that could be beneficial as well. So that research really does pay off. Anything to add?
It always gets worse before it gets better.
Absolutely.
Other questions?
Initially.
Yeah.
I think it's much better.
Other questions?
Any free material or website available for more learning?
So to start with today's presentation, the whole session will be available for you recorded to access it anytime you want. We'll see if we can take some extracts from the presentations and distribute it, but obviously not all the slides we're able to distribute them. Additional learning or additional free reading material, obviously, other than the paid courses that we offer. But Matt or Carl, if you know, or Tammy, if you know additional free access material, they can go to.
Yes. Yeah, on the AHIMA website, we have all kinds of resources available. There's we've got publications, we've got toolkits, we have different publications out there and available that are free. I'm trying to think, and we also do like even some free webinars. If you get on our like our email list, there'll be free sessions that come up from time to time as well. So there's quite a bit of offerings in there that are at no charge to help.
And one thing I'd recommend as well, we have an international bulletin. You can subscribe to that on our website, and that we often put out useful pieces of content about anything related to HIM, but a lot of stuff on CDI in there. So if you're interested, our international bulletin on our website will have free resources there as well. Other questions, thoughts, worries?
Let's try 2 more questions if we can reach it.
Okay, one more question.
1 more question. We'll hit the target. Okay. So I think that's it.
Yep, thank you for your time. We appreciate the opportunity, and thank you, Bill, for having us. Thank you.
And I'd like to thank AHIMA also as well for being here. Thank you everyone for attending. It was a lovely day. I hope we were beneficial to you. We added to your knowledge. We'd like to hear back from you. You have our contact details. We're always here to help. Thank you very much.
Thank you.
Assalamu alaikum.